What's up, everybody? Today we'll do another set of 75 high-yield NCLEX-RN questions for you to practice. So let's get started with the first part of 3 sections. Question number 1. A 7-year-old child with autism who is nonverbal and has minimal eye contact is being assessed by the nurse. What is the best first step to encourage social interaction? A. Participate in parallel play, sitting alongside the child. B. Prompt the child to sing songs with the nurse. C. Offer the child chances to play with other children. And D. Implement therapeutic holding if the child does not engage in verbal communication. The answer here is letter A. And why is that? Because it meets the child where they are in terms of comfort and social ability. And take note that kids with autism, especially those who are nonverbal, often engage in parallel play, playing next to someone rather than directly with them. And by doing the same, the nurse enters the child's world in a non-threatening way. And over time, this can build trust and gradually encourage interaction. And it's all about creating safe, familiar space for the child to open up at their own pace. Now, why is letter B incorrect? It sounds fun, right? But for a nonverbal child with autism, this could feel overwhelming. And we know that singing requires verbal expression and social engagement, which might be too much for them at this stage. Instead of encouraging interaction, it could create stress and cause the child to withdraw. And starting with indirect, non-intrusive interaction like parallel play is a much better way to ease into social engagement. Letter C is also incorrect. We know that peer interaction is an important long-term goal, but it's not the best first step. We know that many children with autism spectrum disorder struggle with direct peer interactions, especially if they have minimal verbal skills and poor eye contact. Now, if social play is introduced too soon, the child might feel pressured or frustrated, leading to withdrawal. Now, a better approach is to first build rapport with the child through parallel play before gradually introducing structured peer interactions. Letter D is also incorrect. This is a big no because therapeutic holding is used in situations where a child is at risk of harming themselves or others, like if they're having a meltdown or engaging in self-injurious behavior. But here, the child is simply nonverbal and not engaging socially, which doesn't warrant physical restraint. In fact, forced physical contact could make things worse by increasing the child's anxiety, or it can trigger sensory overload. And the better strategy is to build trust through gentle, not threatening interaction. Again, parallel play works well with this scenario. Now, a final takeaway in this question is that you gotta remember that when a child has autism, especially one who is nonverbal and has limited eye contact, social interaction should be encouraged gradually and in a way that respects their comfort level. And the parallel play mentioned in letter A allows the nurse to be present and engage without demanding too much too soon. And over time, this can help build trust and also can encourage the child to interact at their own pace. Let's have number 2. A 45-year-old patient arrives at the emergency department after a motor vehicle collision. The patient is pale, diaphoretic, and reports dizziness and weakness. Vital signs are as follows: heart rate 124 beats per minute, blood pressure 80/48, respirations 24 cycles per minute, and oxygen saturation of 95 on room air. The nurse notes cool, clammy skin and delayed capillary refill. The patient mentions taking aspirin daily for heart health. What actions should the emergency department nurse prioritize for this patient? Select all that apply. A. Obtain an order for blood type and cross-match. B. Insert an 18-gauge intravenous catheter. C. Place the patient in a reverse Trendelenburg position. D. warm the patient by covering them with blankets, and E, complete the patient's admission procedures. Now, what is going on in this question? The patient is showing signs of shock. There's tachycardia. There's hypotension, suggesting that the body is struggling to maintain perfusion. And the nurse's priority here is to stabilize circulation and prevent further deterioration. Now, the answers are the following. We have letters A, B, and D. Why letter A? Well, it's an absolute correct answer. If the patient has been taking daily aspirin, they may have impaired clotting ability due to aspirin's effect on platelet aggregation, and this increases the risk of significant bleeding, which could contribute to their low blood pressure and tachycardia. And so a type and cross-match is essential to prepare for a possible blood transfusion. It can ensure the patient receives compatible blood if needed. Letter B is also correct. Yes, a large bore IV, at least 18 gauge, is needed because we're dealing with fluid resuscitation or blood transfusion. We know that in shock, we're going to need rapid IV administration as to maintain blood pressure and organ perfusion. And take note that smaller IV, well, it will cause slower infusion, so a large bore catheter is non-negotiable in this situation. Letter D is also correct. Well, why? Because shock often leads to poor circulation and peripheral vasoconstriction, which makes the patient feel cold, and keeping them warm with blankets or warming devices can help prevent hypothermia, which can worsen their condition. Now, why letter C is not to be done? Well, we know that reverse Trendelenburg, which is basically head up, feet down, isn't going to help here. So if anything, would want to keep the patient flat or even elevate their legs, which is what we call as modified Trendelenburg, to promote blood flow back to the heart. But even positioning isn't the first priority. We need to administer IV fluids and blood products as needed. Letter E is also incorrect. Definitely not. Admission paperwork is something that we can do a later time, and we need to make sure that we are treating first the shock and do stabilize the vital signs, and those are our priority, not documentation. Now, once the patient is stable, then we can now worry about any type of forms. Now, this question is about prioritization. When a patient is in shock, you got to get ready for that IV fluid administration, making sure that we have established a large IV access, and also to possibly do that cross-matching, because there's a possibility that we're going to have to administer the blood transfusion, and also to prevent hypothermia. And everything else, positioning and paperwork, can wait, and the position that is mentioned in the options here is basically incorrect. So you got to get rid of that. We have number 3. A client with a partial blockage in the left common carotid artery has been receiving IV heparin and is now prescribed warfarin concomitant. The client asks why both medications are needed at the same time. How should the nurse explain this approach? A. It ensures immediate and maximum protection against blood clot formation. B. It allows existing clots to break down while preventing new ones from forming. C. It maintains anticoagulation through IV therapy until the oral medication reaches a therapeutic level. And D. It enables the use of lower doses of each anticoagulant. The answer here is letter C. Now, let's break down this question. It's going to test your understanding about bridging therapy. This is the overlapping of the intravenous heparin with the oral warfarin, and this will ensure continuous anticoagulation. Now, what I want you to do here is to look for those word clues in the questions. There's that partial blockage in the left common carotid artery. So take note of the key word here. This suggests that the client is at risk for stroke due to clot formation. Another is receiving heparin therapy right here. Okay, and now patient is prescribed warfarin, Coumadin, which is basically a mix of the rapid acting, or this is the fast acting anticoagulant, which is the IV heparin, and we have the warfarin, which is basically a slow acting type of Coumadin, which is slow acting type of anticoagulant. And so this is going to be used for long term. All right, now I want you to focus on the timing and the drug action. Well, we know that heparin works immediately, but is short acting. It stops working quickly when it is discontinued. Now, warfarin takes about 2 to 3 days to reach a therapeutic level because it affects the synthesis of clotting factors in the liver. Now, look for an answer that explains why both drugs are given together for a period. Now, the correct answer here is C. Why? Because it maintains anticoagulation, though IV therapy, until the oral medication reaches a therapeutic level. So, because again, warfarin takes about several days to become effective. Now, I want you to focus here that during the transition, IV heparin continues to provide anticoagulation to prevent clot formation. And once warfarin reaches a therapeutic INR level of 2 to 3 for most condition, or maybe 2.5 to 3.5 for higher risk patients, then heparin can be stopped as ordered. Now, the key concept here in this question is that the bridging therapy is a standard practice in anticoagulation management. Don't forget about the word bridging. Now, why is letter A why is it incorrect? Well, it sounds good, but it is misleading. We know that both drugs provide anticoagulation. They don't increase the total protection beyond what is needed. And more importantly, warfarin is not immediate. So this option doesn't address the reason for overlap. Letter B is also incorrect. Watch out for the idea of clot breakdown. That's a red flag. We know that neither heparin or the warfarin dissolves clots. They don't. They only prevent new ones from forming. We know that clots dissolve over time naturally or with thrombolytic drugs like TPA, which are not part of this treatment. So this is something that you should eliminate right away. Break down clots. This is not the action of the anticoagulant. Letter D, this is also incorrect. It's not true. Heparin and warfarin act on different parts of the coagulation cascade, and their dosages are adjusted independently based on PT-INR for the warfarin and APTT for the heparin. And so lower doses of one do not mean lower doses of the other. Now, final takeaway here about this question is to make sure that you identify the main concept of bridging therapy with heparin and warfarin, and recognize the word clues. Again, IV heparin, and now the patient is prescribed warfarin. This is now a transition period. Now, I want you to eliminate answers that mention clot breakdown or incorrect drug actions and choose the option that explains the need for anticoagulation continuity. Now, let's have number 4. A client diagnosed with Lyme disease is prescribed oral doxycycline or vibramycin as part of the treatment. What is the correct way for the use to administer the medication? A. Give antacids 30 minutes after the dose if the client experiences gastrointestinal discomfort. B. Provide the medication at least 1 hour before consuming dairy products. C. Administer the drug with food or a light snack. And D. Serve the medication with citrus fruit juice such as orange juice. Now, what I want you to look into this question is basically going to, for these words, doxycycline, which is a vibramycin. This is a tetracycline antibiotic. It has specific administration guidelines. Now, also look for the word the administration of the medication is also a key here. The correct way for the nurse to administer. Okay, this is signaling you to need to find the answer that allows the best nursing practice for medication absorption. And you have to focus on what affects doxycycline absorption, such as dairy products, antacids, iron supplements that can interfere with the absorption. And also take note that this medication should be taken on an empty stomach at least 1 hour before or 2 hours after meals. And this is a drug that is not really affected by citrus juices, right? And this is not going to be a necessary component of the administration. Now, what is the answer here in this question? We have letter B. Why is it? This is the best choice because calcium-rich foods like dairy can significantly reduce absorption of doxycycline, and the nurse should ensure the client takes it at least 1 hour before or 2 hours after consuming dairy. And also recall that the Lyme disease, take note of this problem. This is that problem that is actually attacking the digestive tract and also the nervous system. It will slow down the motility. And so essentially the muscles that move food through the digestive tract become paralyzed and food builds up. It can lead to nausea, vomiting, constipation, and pain. Now, why are the other options incorrect, such as A? You got to watch out for this because antacids contain aluminum, magnesium, which can bind with the doxycycline and it reduces the absorption. And so if a client experiences gastrointestinal discomfort, which you can also do an alternative approach here, like taking the Vibramycin with a full glass of water or lying down only after half an hour. So making sure that the patient is sitting upright for at least 30 minutes after taking that medication. Letter C is also incorrect. Well, why is this incorrect? This is misleading. We know that food can reduce gastrointestinal upset, but it can also decrease the absorption. And the best practice to administer doxycycline is on the empty stomach, and also to administer or give or have the client take plenty of water to reduce esophageal irritation. A glass full of water. Now, letter D is also wrong here. This is tricky, but wrong. Citrus just doesn't significantly affect the doxycycline absorption. However, some tetracyclines can cause esophageal irritation and acidic drinks may worsen that discomfort. So water is the best choice. Now, final key takeaways here in this question, you have to identify first what the medication is being administered. Again, it has specific absorption rules, and take note of the keywords dairy products, correct way to administer, and Lyme disease. These all point to absorption consideration. And you make sure that you eliminate wrong choices based on drug interactions, especially antacids, food, citrus juice, which are either harmful or just unnecessary for this medication administration. Now, you also need to choose the best option that ensures proper absorption, avoiding calcium, antacids, and take the medication on an empty stomach. Now, let's have number 5. A parent informs the nurse, my 9-month-old no longer grips objects firmly like they did at birth and doesn't react to loud noises as before. How should the nurse address these developmental changes? A. I will assess these reflexes first before providing further guidance. B. These reflexes naturally disappear by around 5 months as the baby develops voluntary movements. And C. The absence of these reflexes could indicate a possible developmental issue. And D. Providing more sensory stimulation can help these reflexes return. Now, this question is testing your knowledge of the infant reflex development and normal growth patterns. And the word clues in the case scenarios are 9-month-old, This tells us the child is well past the newborn stage and also no longer grips objects firmly like they did at birth. It refers to the grasp reflex, which disappears by 3 to 5 months. And the other set of words here are doesn't react to loud noises as before. So this refers to the startle motor reflex, which disappears by 4 to 6 months. Now, since these primitive reflexes naturally fade as the nervous system matures, the correct response should reassure the parent that this is a normal developmental process. Now, the answer here is letter B. Yes. Primitive reflexes like the grasp, motor reflexes will disappear as the baby's brain matures and voluntary movements take over. And by 9 months, an infant should be using purposeful grasping, not reflexive gripping. And so if these reflexes were still present, it could suggest neurological immaturity or developmental delay, but their absence at this age is completely normal. Now, why is letter A, C, D are all incorrect? Well, letter A is a test-taking trap. Yeah, this sounds like a reasonable nursing action, but the question describes normal development. So further assessment is not needed here. And if the reflexes were still present, then assessment would be necessary. Letter C is also incorrect. Another test-taking trap. This is the opposite of the truth. The reflexes should disappear because if these reflexes persisted beyond 6 months, that would be a red flag for developmental issues, not their disappearance. Letter D is also incorrect. Another test-taking trap here because the reflexes don't return with stimulation because they are part of early neurological development. Now, the focus at 9 months should be on encouraging purposeful motor skills like grasping toys, crawling, pulling to stand, not reinforcing lost reflexes. Now, your strategies here would include looking for developmental age. That is your clue to the question. And also, you have to recall the normal versus abnormal reflex persistence because reflexes disappear. All right? And also avoid over-assessing normal findings. You eliminate answer choices that suggest unnecessary action. And lastly, you gotta be cautious of answers that contradict normal developmental milestone. All right. So with this type of question, we know that the parent's concern is understandable, but their baby's reflexes disappearing is a good sign. It means their nervous system is developing properly. Let's have number 6. A nurse reviews lab results for a client at 24 weeks gestation. Which of the following values should be communicated to the healthcare provider? A, white blood cell count of 10,000 per cubic millimeter. B, fasting blood sugar reading of 92 milligrams per deciliter. And C, platelet count of 240,000 per cubic millimeter. And D, hemoglobin level of 10.9 grams per deciliter. Now, this question is testing your knowledge of normal pregnancy-related lab values and what findings require further evaluation. Now, your key strategies in answering this question should be one of the following. A phrase should be communicated to the healthcare provider. This tells you that one of these values is abnormal or concerning. And another clue would be the 24 weeks gestation. It means that the client is in the second trimester where there is hemodilution and there's also anemia risk, which is actually common. Now, the correct answer for this question is letter D. And why is that? Because normally for women, the hemoglobin is around 12 to 16 grams per deciliter, right? And in pregnancy, blood volume expands leading to dilution of red blood cells. This is what we refer to as physiologic anemia. Now, take note that if the hemoglobin drops below 11 grams per deciliter, it meets the criteria for anemia, which may indicate iron or folic acid deficiency. Now, the healthcare provider needs to be notified so the client can be evaluated for iron supplementation. And so, letter D is the correct answer here. Now, why are letters A, B, and C are incorrect? Specifically, letter A this time. Well, a white blood cell count of 10,000 might seem high in a non-pregnant adult, but pregnancy raises white blood cells naturally. So there is some slight of elevation, even though it's still in the normal range. And take note that the normal white blood cell count in pregnancy usually will be slightly higher, about 5,000 to 15,000 per cubic millimeter. So this is expected at 24 weeks. Now, letter B is also incorrect. This is a test-taking trap. The blood sugar is crucial in pregnancy, but this number is completely normal, and the expected fasting blood glucose range around this time should be around 70 to 105 milligrams per deciliter. And so a red flag would be persistently elevated glucose. So it can possibly indicate gestational diabetes. But in this scenario, this is fasting glucose of 92. Now, letter C, platelet count of 240,000. Another test-taking trap. So you might worry about platelets dropping in pregnancy due to gestational thrombocytopenia. However, a normal range is somewhere around 150,000 to 400,000, and 240,000 is well within normal limits. So what you need to do in this test question, you got to identify the key lab values affected by pregnancy, and these are the hemoglobin, white blood cells, and also platelets. And you have to eliminate those answers that fall within normal pregnancy ranges, and to recognize those common pregnancy-related conditions such as the physiologic anemia, gestational diabetes risk. And lastly, you have to focus on what requires healthcare provider notification. Let's say minor variations in white blood cells and platelets do not. Anemia does. All right. Let's have number 7. The unlicensed assistive personnel reports that a client 4 hours after a transurethral resection of the prostate has red urine with some clots. What should the nurse do first? A. Medicate for bladder spasms to decrease bleeding. B. Notify the healthcare provider that the client has gross hematuria. And C. Assess the client's urine output immediately. And D. Explain that this is expected with this surgery. Now let's break down the question here. This question is focusing on a post-op scenario after a TURP, that's the transurethral resection of the prostate. And the goal about this question is to determine what the nurse should do first when the unlicensed assistive personnel reports red urine with some clots in a client who has had TURP. Now, your test-taking strategy here is to look for the clue in the stem, which is basically the patient is 4 hours post-TURP, and the UAP is reporting red urine with clots. This is important because TURP surgeries involve bleeding and post-urinary changes that are expected in the first few hours. And the question itself is asking what the nurse should do first. So the key is to prioritize actions based on expected complications versus immediate interventions. Now, the answer here is letter D. And why is that? Explain that this is expected with the surgery. The red urine with clots is a common and expected finding after this TURP surgery. And after a TURP, the patient will end up with a 3-way indwelling catheter. And the reason for that is to allow flushing, continually flushing with the use of the irrigant into the bladder to help clear blood and clots. And it's normal or expected to see some bloody urine and small clots for the first few hours. And the first nursing action for this scenario is to explain and reassure that UAP and also the patient that this is part of the normal healing process. Now, why is letter A incorrect? Medicate for bladder spasms to decrease bleeding. This is a test-taking trap. The stem in the question doesn't mention anything about bladder spasms, and bladder spasms may happen after the TURP, but this is not the primary cause of the bleeding here. The bleeding is related to clots, not spasms. And medications for spasms are not the first priority unless spasms are actually present. Letter B is another test-taking trap because gross hematuria, which is basically visible blood in the urine, is expected after TURP and doesn't require immediate notification to the healthcare provider unless the bleeding becomes excessive or uncontrollable, meaning the color of the urine output is not going to change from being red into pinkish when the irrigant is being increased, right? So it's important to recognize that normal post-op findings don't always require action unless they deviate from expected trends. Letter C is also incorrect. This is another test-taking trap. We know that it's important to monitor urine output, but this scenario specifically mentions red urine with some clots, which is expected in the several hours or first few hours after the procedure. And the priority is to explain to the patient that this is expected and also explain it to the UAP. And take note that urine output assessment is part of the ongoing monitoring, but not the first step when dealing with expected post-op findings. Now, you need to strategize in answering this question by prioritizing the expected and also reassuring action. The stem of the question points to a normal post-op finding, which is the bloody urine with the clots. And the nurse here should first educate and reassure the client and also with the UAP. And you also need to recognize that normal post-op patterns because TURP surgeries often result in initial bleeding, and don't be swayed by the word clots if it's a normal part of the healing process, right? And you also need to watch for first or priority keywords. The question is asking what to do first. So always consider if a normal finding requires immediate action or reassurance. Again, the case scenario here doesn't reflect a very complicated case after the procedure. It doesn't. It's actually portraying a normal expected occurrence. All right. Let's have number 8. A client is receiving total parenteral nutrition through a subclavian line, but bag number 6 is unavailable and only 50 ml of TPN remains in bag number 5. What should the nurse do? A. Infuse D10 water at 125 ml per hour through subclavian line. B. Prepare to hang a 1000 ml bag of normal saline. C. Slow the infusion rate of bag number 5 to a keep open rate. And D. Convert to a heparin lock when bag number 5 is empty. Now, this scenario involves the client on TPN through a subclavian line, and the nurse here is faced with a situation wherein the TPN bag is number 6 is unavailable, and only about 50 ml remains in the bag number 5. And so you're going to decide how to proceed to prevent complications, particularly hypoglycemia, while you are waiting for the arrival of the next bag of the TPN. Now, your strategy here is to find the clue in the stem. Again, that is the TPN. Okay? And the concern is that the next bag is unavailable. All right? This indicates that the priority is to maintain the client's blood sugar levels until the TPN can continue. So the question here is asking what the nurse should do immediately. And so the answer needs to focus on preventing hypoglycemia and also managing the current infusion properly. And so the answer to this question is letter A. And why is it correct? We know that dextrose 10% water is an appropriate solution to maintain glucose levels in the absence of TPN. And we know that TPN provides glucose and other nutrients, and abruptly stopping it can cause hypoglycemia. No, we don't want that. And the D10 water in option A provides enough glucose to help prevent hypoglycemia until the new TPN bag arrives, and this ensures the blood sugar levels are stable. And so the 125 mLs per hour rate is an adequate infusion rate for this IV fluid. It can allow the blood sugar to be delivered, it can allow the glucose rather from the bag to be delivered while waiting for the next TPN bag. Now, why is letter B incorrect? Prepare to hang a 1 liter bag of normal saline. This is a test-taking trap. Well, we know that normal saline does not contain any glucose. It does not, which will not help to prevent hypoglycemia. And so again, without glucose, the client is at risk for low blood sugar because TPN provides essential glucose that is now missing. And so this option B would be a poor choice because it doesn't address the immediate concern of maintaining blood sugar levels. Letter C is also incorrect, another test-taking trap, because when you are slowing the TPN infusion, this can reduce the amount of glucose the client receives. It also increases the risk of hypoglycemia. And TPN should not be abruptly stopped or reduced without transitioning to an appropriate glucose-containing solution. And a keep open rate, or a KVO, or a TKO, to keep open, would also not provide the necessary glucose, so it doesn't solve the problem at hand. Letter D, another incorrect option, because heparin lock would stop the TPN infusion, which is exactly what we're trying to avoid, because the client still needs the nutrients and the glucose from the TPN. And so the concern is to maintain glucose levels until the next TPN bag arrives, and the heparin lock that is being presented in option D would interrupt the treatment. Basically, you're just you're just keeping an anticoagulant inside the central line to prevent it from clogging, right? So basically, you are interrupting the treatment, which is basically stopping the nutrition by not providing any other sources of glucose. And this can lead to hypoglycemia as well. So your strategy here would be to look for the clues about the primary concern. Again, the client is receiving TPN. So the primary goal is to maintain glucose level and to prevent hypoglycemia when the TPN bag runs out. Let's have number 9. A client with end-stage heart failure is being cared for by a home health nurse. What instruction should the nurse give to the caregiver? A. Report any time the client experiences difficulty breathing. B. Show the caregiver how to measure the client's apical pulse for 1 full minute. And C. Encourage the client to do 30 minutes of exercise each day. And letter D. Instruct the caregiver to notify the healthcare provider if the client gains more than 3 pounds in a week. Now, this question involves a client with end-stage heart failure and what instruction the nurse should give to the caregiver. And the focus is on symptom management and when to seek medical advice for any significant changes in the client's condition. Now, how are you going to strategize in answering this question? Well, you gotta look for the clue in the stem, which is end-stage heart failure. All right, that's a big clue right there. And so we are looking for instructions related to monitoring symptoms, let's say fluid retention, maybe changes in weight, and we need to be mindful of what's appropriate for end-stage heart failure. And since the question asks what instruction to give the caregiver, so you got to think about what's most urgent in managing the patient's worsening condition. So the correct answer here is letter D. Why is it correct? Well, a weight gain of 2 to 3 pounds within a short period, let's say a week, is a classic sign of fluid retention in heart failure. And this weight gain should be reported immediately to the healthcare provider because it can indicate worsening heart failure and possibly a need for adjustments in the treatment, maybe an increase in the dose of the diuretics. And take note that fluid retention is a common and dangerous complication in an end-stage heart failure. So the nurse is teaching the caregiver to be vigilant about weight gain. Now, why are the other options incorrect, like A, B, C? Now, let's start first with letter A. Yes, this is a test-taking trap. Take note that shortness of breath is common in heart failure, especially in end-stage disease. However, in this case, the key instruction should focus on significant changes that could indicate a worsening condition. And take note that shortness of breath with activity is expected and not always a red flag, and the caregiver should only report shortness of breath that doesn't resolve with rest or stops after the activity is stopped. And so this answer would be too broad and not as useful in this context. Okay? We know that shortness of breath is one of the telltale signs, but again, it is too broad. Now, what about letter B? Another test-taking trap here, because measuring the apical pulse is more relevant if the client is on digoxin, and as a nurse would need to ensure the pulse is above 60 beats per minute before administering the medication. But this client, this option is not going to address the primary concern for a client with end-stage heart failure, which is fluid retention and weight gain. And again, take note that end-stage heart failure requires focus on fluid management. So this instruction isn't the most urgent or the most relevant for this particular situation. Again, it's not the most urgent, not the most relevant. Okay, take note about those words right there. Letter C is also incorrect. This is another test-taking trap because a client with end-stage heart failure is unlikely to be able to tolerate 30 minutes of exercise. In fact, activity intolerance is often the hallmark of severe heart failure, as the client's cardiac output is insufficient to meet the body's demands. And encouraging exercise in this case could be dangerous and inappropriate because of the decreased tolerance to activity in end-stage heart failure. All right, this is inappropriate advice. Now, your critical test-taking steps here again is to focus on what is life-threatening and most relevant for the client's condition. Again, we are talking about fluid retention, and worsening symptoms are key issues to address in this question. Again, the weight gain that is rapid, which is a sign of worsening heart failure. So that becomes priority. And you also have to take note about avoiding too broad answers, such as the option A. All right. And you also need to consider the context of the disease, that in end-stage heart failure, the focus is on managing fluid balance and preventing complications from worsening fluid retention, not on things like exercise or addressing the apical pulse unless specific medications are involved. All right, let's have number 10. A 32-year-old male client with a spinal cord injury has developed paraplegia. During the early phase of recovery, which primary challenge should the nurse anticipate? A, learning to walk with assistive devices. B, managing bladder function. C, maintaining adequate nutrition. And D, strengthening the quadriceps. All right, so this question is about a 32-year-old male client with a spinal cord injury who has developed paraplegia. So it's asking you about the primary challenge the nurse should anticipate during the early phase of recovery. That's a big clue right there. Early phase recovery. Now, what are the key strategies for you to effectively answer this question? Well, you have to look for that clue in the stem. It mentions that early phase of recovery and the word paraplegia. All right. So this gives you a time frame and also focuses on the initial complications that occur with spinal cord injury, and specifically about bladder control, which is commonly affected. Now, you need to look for those options that focus on early complications after a spinal cord injury rather than long-term goals or rehabilitation goals. And so the correct answer is letter B. And why is it the correct answer? We know that the sacral region of the spinal cord controls the micturition reflex, which is responsible for the bladder function. And the injury to this area can result in loss of bladder control, can lead to urinary retention or incontinence, which are commonly early challenges in spinal cord injury recovery. And in the early phase of recovery, managing bladder function is a primary concern, as it can lead to urinary tract infections. Renal failure can also lead to autonomic dysreflexia if not properly managed. Again, those are key complications in the early phase. Okay. Now, why is letter A incorrect? This is a test-taking trap because ambulation isn't typically the primary concern immediately after a spinal cord injury that results in paraplegia. All right. So in the early phase of recovery, the focus is on stabilizing vital functions and also addressing immediate complications like bladder control. And so learning to walk in this option, or let's say using assistive devices, would be a goal in the later phases of rehabilitation, not during the initial recovery stage. Letter C is also incorrect. Another test-taking trap. We know that nutrition is important in any recovery process. It's not usually the primary challenge in the early phase of spinal cord injury recovery, because the most immediate concerns are typically related to, again, neurologic and autonomic functions like bladder control, breathing, and also skincare rather than nutrition. Of course, adequate nutrition becomes focused later on to support the healing, but it's not the primary concern at this stage. Letter D, strengthening the quadriceps. Another test-taking trap. Take note that the strengthening muscles like the quadriceps would require motor control, which the patient with a spinal cord injury at the paraplegia level may not have in the early phase of recovery. This is especially true if there is a complete loss of motor function in the lower extremities. And early in the recovery, the focus is on preserving function, preventing complications, and possibly using assistive devices, not on strengthening muscles that the client currently cannot control. So your test-taking skill here is to focus on the early phase of recovery. That is your clue. All right. Again, in the early phase, the primary goal is to address immediate complications like bladder control, not those long-term goals like ambulation or strengthening muscles. All right. Let's have number 11. A nurse is examining an elderly patient who has been diagnosed with dementia. What signs would you anticipate observing in this patient? Select all that apply. A, difficulty adjusting to new situations. B, failure to identify familiar items. C, challenges in engaging with new hobbies or activities. D, focus on past events while disregarding current circumstances. E, obsession with appearance or grooming. Now, this question asks about the signs and symptoms to anticipate in a patient with dementia, specifically focus on the elderly population. And your task here is to select the appropriate manifestations of dementia, which often leads to cognitive dysfunction and altered behavior. Now, what are your strategies to answer this question? Well, you have to look for the clues in the stem. It specifies that the client here has a dementia, okay, which involves cognitive decline, and this should direct your attention to the cognitive and also the behavioral symptoms, such as memory problems, disorientation, and also difficulty with familiar tasks. Now, what are the correct answers here? Let's have letters A, B, C, and D. Let's start with letter A, difficulty adjusting to new situation. In dementia, often it can cause resistance to change, making it difficult for them to adjust to new environments or routines. And the patient that has dementia may feel more comfortable with a structured, predictable environment. And so difficulty adjusting to new situations or surroundings or environment is a typical cognitive challenge seen in dementia. Letter B is also correct. This is a hallmark of agnosia, which is a condition in which the patient cannot recognize or cannot identify familiar objects, even though their vision and senses are intact. And so this is a common cognitive dysfunction seen in patients with dementia as well. Letter C, another correct option, because individuals with dementia often have a short attention span and they may lose interest in new activities or hobbies. And so this is a result of cognitive decline that impacts their ability to concentrate and learn new things, which can affect their participation in activities. Letter D, another correct option, because many patients with dementia have long-term memory retention for past events, but they struggle with short-term memory and current reality. And as a result, they may often focus on past events and may even act as though they are still living in the past. And this can cause them to disregard present circumstances. And so letter E is the incorrect option here. Obsession with appearance or grooming. Why is this incorrect? We know that people with delirium or other cognitive disorders such as depression may exhibit changes in behavior or appearance, but dementia is less likely to cause an obsession with appearance or grooming. And again, I want you to recall that patients with dementia typically lose interest in personal grooming, and they may need assistance with basic hygiene tasks, and they may also show indifference to their appearance, focusing more on internal experiences rather than external concerns. So I want you to pay attention to the strategies here. Again, identify the keywords related to dementia, words like cognitive dysfunction, memory recognition, and also resistance to change. And these should trigger the focus on the symptoms related to memory loss, the disorientation, and also the behavioral changes that you commonly seen in a patient with a dementia. All right. Now, you also need to exclude those symptoms not typical for dementia, such as obsession with appearance. It's not a common sign of dementia, and it could hint another condition. Let's go to number 12. A 3-week-old baby undergoes surgery to correct hypertrophic pyloric stenosis, or HPS, after being formula fed. Which post-op feeding plan is most appropriate? A. Additional glucose feedings can be given as needed after the first 24 hours. B. The baby can resume regular formula feedings with a day after surgery. And C. Formula feedings should be thickened starting 24 hours post-surgery. And D. All feedings should be withheld for the first 24 hours. Alrighty. Now, when answering this question, you need to focus on the typical post-op care plan for a 3-week-old baby after surgery for hypertrophic pyloric stenosis. And the key here is to understand the general principles of feeding after surgery for a newborn, specifically after a pyloromyotomy, which is done to correct this problem. And so what you're going to need to do here is to focus on the wording of the question. It's asking specifically, mentioning the post-op feeding plan. All right. And so think about gradual resumption of feeding after surgery. Now, another strategy for you is to look for the clues related to typical post-op feeding protocols for the neonates. And infants, especially those with HPS, typically need clear fluids first, and the formula feeding is resumed gradually based on their tolerance. Now, I want you to avoid overcomplicating the answer with unnecessary interventions, such as thickening formulas or withholding all feedings, unless it's medically justified. And so the correct answer here is letter B, right? Because after a pyloromyotomy, which is the procedure for the HPS, the infant's feeding is generally reintroduced cautiously. And so initial feedings are typically glucose and electrolyte solutions or breast milk for the first few hours post-surgery. So we're talking about usually 4 to 6 hours. And when the baby tolerates these clear liquids or fluids, formula feedings are generally started within 24 hours, and this aligns with the standard care protocols and also allows for a gradual return to normal feeding. Again, the word is gradual return, gradual transitioning of the diet from clear or with a glucose into breast milk, as long as the baby is tolerating them. All right. Now the incorrect options here. Letter A. Why is it incorrect? Because this option introduces an unnecessary complication. Because after the first 4 to 6 hours post-surgery, clear fluids like glucose, water, or breast milk are introduced. All right. Once the baby tolerates these, the regular formula feedings are typically start within 24 hours, and there's no need for additional glucose feedings after the first 24 hours if the patient is tolerating other feeds. So this is not the correct approach. Letter C, another incorrect option, because the key after surgery is to gradually reintroduce normal formula feedings as the baby tolerates clear liquids. And thickening the formula is generally not recommended unless there is an issue with a feeding tolerance, such as reflux, which is not indicated in this question. And the goal here is to reintroduce regular formula as the baby's digestive system recovers without complicating it by thickening the formula prematurely. Letter D, another incorrect option. This is an extreme approach that is not supported by the typical post-op protocol for HPS surgery. And I want you to know that after pyloromyotomy, withholding the feedings for 24 hours is unnecessary, as glucose, electrolytes, or breast milk are started just after a few hours and followed by regular formula feedings after 24 hours. So there's no need to withhold all feeding. So again, just recapping for you to use the strategies, you need to understand the typical post-op progression. Again, newborns who undergo HPS surgery are usually started on clear liquids first. We're talking about glucose or breast milk. Then regular formulas is gradually reintroduced within 24 hours. So avoid any interventions that are too extreme or unnecessary, like withholding all feedings or thickening thickening formulas. And so you also need to pay attention about the timeline. The timeline here is about the 24-hour mark, which is key in this scenario. Again, formula feedings is typically resumed within 24 hours. So any answers suggesting delaying feedings or additional steps are likely incorrect. Let's have number 13 after this break. So we are inviting you to join Stancoast NCLEX coaching today and get access to all these amazing stuff. We have about 300 hours of animated video course and on-demand videos you can watch anytime. There's over 10,000 practice questions. You're going to be provided with audiobook and ebook, and you will have access to the mock tests, computer adaptive tests, and test series to give you a real exam experience. And this includes 200 plus NGN questions, and this is accessible in 12 months. So head over to stancoastnclexcoaching.com and start your path to NCLEX success today. Let's have number 13. A client is scheduled for hemodialysis. What should the nurse do before the procedure? A. Check the client's weight to establish a reference point for fluid removal. B. Explain that the peritoneum functions as a filter for removing waste from the blood. C. Collect a urine sample to assess renal function. And D. Administer any medications that are due to be given within the next hour. So to answer this question effectively, it's important to understand the specific procedures and preparatory steps for hemodialysis, which is a type of dialysis used to treat kidney failure. We are talking about hemodialysis. So I want you to look for the clues in the questions that refer to hemodialysis specifically, not peritoneal dialysis or general kidney function. So focus on the key monitoring steps that are part of the hemodialysis process and which would be necessary before the procedure is done. Now, why we have letter A as the correct answer for this question? Why is it correct? Well, before starting the hemodialysis, it's very critical to check the client's weight. This is going to serve as baseline information to determine how much fluid has accumulated since the previous dialysis session. And we know that weight is an important factor in determining how much fluid needs to be removed to bring the patient back to their dry weight, which is the weight they should ideally have once excess fluid is removed. Now, why is letter B incorrect? This option refers to a peritoneal dialysis, not hemodialysis, okay? We know that in hemodialysis, blood is filtered through a machine, not the peritoneum, all right? And understanding the distinction between hemodialysis and peritoneal dialysis is key. Each method has different mechanisms, so in filtering the waste. So this is, since this is specifically asking for hemodialysis, option B is incorrect. What about letter C? Another test-taking trap, because clients with advanced kidney disease or maybe those who require hemodialysis may not produce urine due to the loss of kidney function. So this option is not necessary, okay? Collecting a urine sample in this case is unnecessary, especially since the primary purpose of hemodialysis is to filter the blood, not assess urine output. Okay, take note, guys. People that undergo hemodialysis and also peritoneal dialysis, usually they will have impaired kidney function. So you're not really going to expect a usual urinary output or a normal urinary output. What about letter D? Another test-taking trap. This is generally not recommended before the dialysis because many medications should be delayed until after the dialysis because they could be filtered out by the dialysis process and it will render the medications less effective. And so medications that are due may be withheld or adjusted depending on the dialysis schedule and the specific medication, and so administering them before dialysis is typically not done. So I want you to focus on the procedure mentioned. You have to pay close attention to whether the question asks about hemodialysis versus peritoneal dialysis. All right, and I also need you to look for the most essential pre-procedure action. And for hemodialysis, the most important action is to establish baseline weight because this is going to determine how much fluid will be removed during the current procedure. All right, let's have number 14. A nurse is performing a neurological assessment for a client following a craniotomy using the Glasgow Coma Scale. Which factors are evaluated to determine the client's score? Select all that apply. A, the level of stimulation required to make the client open their eyes. B, the client's pupil response to light. C, the extent to which the client exhibits purposeful movements. D, the evenness of muscle strength in the client's arms and legs. And E, how appropriate the client's verbal responses are. So in this question, you're asked about the GCS, Glasgow Coma Scale, which is going to assess the level of consciousness and neurological status of a client after a craniotomy. And so the key to answering this question correctly is to know which parameters are specifically measured by the GCS. And as always, I want you to watch for the word clues that indicate what's directly assessed by the scale, such as eye opening, that is one. Verbal response, another is motor response. And I want you to eliminate those unrelated concepts like pupil response or muscle strength, which are not part of the Glasgow Coma Scale. And so the correct answers here are letters A, C, and E. And why letter A? Because the Glasgow Coma Scale assesses the eye-opening response. This is the first of the three components assessed by the GCS. This is the level of the stimulation, whether it's spontaneous to speech or to pain, needed to elicit eye-opening, okay? And whenever there is a higher score, it indicates more appropriate responses. Now, letter C is another correct option here because the GCS also measures the best motor response, which includes purposeful movement. So, for example, movements like obeying commands or purposeful movement in response to the pain are scored, and this reflects how well the client can respond to the stimuli. Letter E is another correct option here because the GCS evaluates or it assesses the best verbal response ranging from appropriate conversation to confused or maybe incomprehensible speech. And the verbal response indicates the client's level of orientation, their cognitive function, and this is another crucial part of the GCS assessment. And so letter B is an incorrect option. We know that pupil response to light is an important neurological assessment, but this is not part of the GCS, okay? And so again, the GCS focuses on eye opening, motor response, verbal response, okay? Now, what about letter D? Evenness of muscle strength, another incorrect option because muscle strength is also, we know that this is important, right? In assessing neurological status, but the Glasgow Coma Scale does not include this assessment scale. Okay, again, the GCS focuses on motor response like purposeful movement or withdrawal from pain, not specific muscle strength or symmetry. So again, I want you to strategize in answering this question. You need to understand the basic components of the Glasgow Coma Scale. Those three: eye-opening, motor response, verbal response, and eliminate those unrelated concepts like pupil response, like the size of pupil. We don't have that. The client's pupil response to light, that's not part of it, okay? Or let's say the muscle strength. You can confidently eliminate those two. Let's have number 15. A 44-year-old client undergoes an amniocentesis at 16 weeks of gestation due to concerns about Down syndrome. What other fetal information can be obtained from the examination of the amniotic fluid at this stage? A, evidence of a neural tube defect. B, the level of lung maturity. And C, a heart malformation. And D, indicators of type 1 diabetes. Now, take note that this question, the key is understanding what amniocentesis can reveal about the fetus at 16 weeks of gestation. All right. The Critical word clues are amniocentesis, 16 weeks, and fetal information. Now, this will help you narrow down the possible options, and amniocentesis is typically performed for genetic testing, but it can also reveal specific abnormalities in fetal development. So knowing what can be tested and when, especially at 16 weeks, will help you in guiding to the correct answer here. Now, what is the correct answer? Well, this is going to be letter A. And why is it? Because at 16 weeks of gestation, the alpha fetoprotein, or the AFP, levels in the amniotic fluid can be measured. And the elevated AFP levels are commonly associated with neural tube defects, such as spina bifida or anencephaly. And this will make the answer A correct, because neural tube defects can be detected at this stage through the amniocentesis by analyzing the AFP in the amniotic fluid. Why letter B is incorrect? Well, lung maturity cannot be assessed at 16 weeks of gestation through amniocentesis. Again, recall 16 weeks. And I want you to recall that lung maturity is typically evaluated in the third trimester, generally after 35 weeks of gestation. And at 16 weeks, the fetus lungs are still in early stages of development, so amniocentesis would not provide accurate information about lung maturity. Letter C is another incorrect option here, as heart malformations are not detectable through amniocentesis. And I want you to recall that amniocentesis is primarily used for genetic testing and screening for neural tube defects, but heart defects would typically require other forms of diagnostic testing like ultrasound or maybe echocardiography. And so the amniocentesis will not really help out in diagnosing this possible issue. Letter D is also incorrect. We know that type 1 diabetes in the fetus cannot be diagnosed via amniocentesis. And while some metabolic disorders can be identified through the amniocentesis, let's say cystic fibrosis or genetic testing, type 1 diabetes is not among the conditions that amniocentesis can detect. All right. So it is a condition related to the mother's health, not the fetus genetic or developmental status, and would not be reflected in the amniotic fluid testing. Now, these are the critical strategies for you to use in answering this question. You need to know the purpose of the procedure. Again, it's used to screen for genetic conditions and detect fetal abnormalities like neural tube defects. And you also have to focus on the developmental stages because there's different testing and screenings available at different stages of pregnancy. And so for the lung maturity, it is not going to be assessed until the third trimester. So the options mentioning that in early pregnancy are easy to be ruled out. You got to discard them right away. And also to eliminate unrelated options. So if the question asks about amniocentesis can reveal, well, you got to eliminate answers that reference conditions not related to genetic screening or those requiring other diagnostic methods such as ultrasound or other blood tests. Let's have number 16. A 10-year-old child with a fractured tibia has had a full leg cast applied. Which findings should the nurse promptly report to the healthcare provider? Select all that apply. A, fiberglass cast is damp for 4 hours after application. B, pedal pulse rate of 90 beats per minute. C, unable to move the toes. D, tingling sensation in the foot. E, increased urinary output. Now, in this scenario, the question is asking you to identify findings that should be promptly reported after fractured tibia has been casted. And for you to approach this question effectively, you need to focus on any symptoms or changes that could indicate complications such as neurovascular compromise or impaired circulation. So you gotta look for the keywords like promptly report and findings suggest that you should look for signs of impaired circulation or nerve function that could require immediate medical attention. So you have to pay attention to any option that references loss of function, sensation, or abnormal findings with the cast itself. Now, what would be the correct answers in this question? Well, these are your letters A, C, and D. Why letter A? Because a fiberglass cast should dry within minutes, not hours. If it remains damp or wet after 4 hours, this is a real red flag because it could indicate improper drying or moisture retention, which can affect the integrity of the cast. And it can also lead to complications such as skin irritation, infection, and also impaired circulation. So this should be reported immediately before further complications can happen. Letter C is also incorrect because if the child is unable to move their toes, this could indicate that the cast is putting pressure on the nerves or the blood vessels, leading to neurovascular compromise. And this is a critical finding because loss of movement in the toes can significantly lead to, this actually signifies compartment syndrome, which is a medical emergency where there's increasing pressure within that extremity, and this can cause permanent nerve damage and tissue death. And so you have to report this to the healthcare provider or surgeon immediately. Letter D, another option that is correct. It's because a tingling sensation, and this is often described by clients as pins, needles. This could indicate nerve compression or impaired circulation due to the tightness of the cast. And this is also a sign of potential neurovascular impairment, which could worsen and could cause further damage. Again, you need to report this promptly to the healthcare provider or the surgeon to prevent complications. And so letter B is incorrect because the normal pulse rate for children 9 years old, we are talking about around 10 years old. And so the typical range here is about 70 to 110 beats per minute. So a pedal pulse of 90 beats per minute is within the normal limits. And it does not suggest any immediate concern about circulation either. So this finding does not require immediate reporting to the healthcare provider. Letter E, another incorrect option, because increased urinary output can sometimes occur due to increased fluid intake or, let's say, the body's response to stress and injury. And as long as the output is not excessively abnormal or accompanied by other symptoms like edema, this is generally not a significant concern and does not require prompt reporting to the healthcare provider. So what I want you to use as strategies in answering this question is to focus on the word or words promptly report. It's asking you to look for those findings that need to be reported immediately. So focus on those signs that indicate compromise to circulation or nerve function, because this can possibly lead to possible irreversible damage into the extremity. And the other clues here are damp cast, okay? It suggests potential infection and also improper drying. Another is unable to move the toes. It indicates potential nerve or circulation impairment. And the tingling sensation could be a sign that there is now nerve compression or possibly ischemia. So also don't forget about the normal ranges for comparison. So for example, in option B, this is just a trap. So you need to recall the normal range for this age group or for this client group. Okay. And think about the overall clinical picture. Consider what could be going wrong with post-cast application phase. So if the cast is still damp or the child has nerve-related symptoms like moving toes, not moving toes or tingling, these are red flags, the 4 complications that need immediate attention. Number 17, when assessing an individual with an anxiety disorder, which clinical findings may the nurse observe? Select all that apply. A, excessive worry about various issues. B, regression to an earlier developmental stage. C, physical symptoms as a manifestation of anxiety. D, redirecting anxiety onto less distressing subjects. And E, acting out in ways that exhibit antisocial tendencies. Now, this question is about identifying clinical findings associated with anxiety disorders, and you have to focus on common symptoms that directly relate to anxiety, such as excessive worry, physical manifestations, and defense mechanisms like regression. Now, I want you to focus on the keywords like anxiety disorder and also manifestation. Okay? You want to capture these to help you identify the behavioral or the physical signs that are linked with anxiety rather than symptoms that are more typical of other mental health conditions. Now, what are the correct answers here? These are letters A, B, C, and D. Why is letter A correct? Because this is a hallmark symptom of generalized anxiety disorder, or GAD. And take note that people with GAD often experience excessive, uncontrollable worry about a variety of issues for at least 6 months. So, if you see persistent worrying about several different areas of life, like work health, relationships, this is a clear sign of anxiety. B is also correct because regression is a defense mechanism where a person reverts to behavior from an earlier stage of development in response to stress. And this is something that can happen in anxiety disorders, especially in children or during times of overwhelming stress. And this is a known coping strategy to deal with anxiety, and it's particularly noticeable in younger individuals, but can also occur in adults. So seeing a person behaving younger than their age could indicate anxiety. Letter C, another correct option here, because anxiety can manifest physically, such as through a muscle tension, could be fatigue, could be sweating, could be palpitations, and also headaches. And these are physical symptoms often appear in anxiety disorders as a direct result of the body's stress response. And this makes sense for conditions like generalized anxiety disorders or panic disorder. Now, letter D, one of the correct options. This is a type of defense mechanism called displacement, wherein the person might transfer their anxiety from a more threatening issue to something less anxiety provoking. And this is common in phobias or generalized anxiety, where a person might focus on less significant concerns to avoid confronting the source of their true anxiety. So this is basically a way the mind tries to decrease anxiety. Now, letter E is the incorrect option among the rest here. Acting out with antisocial behaviors such as aggression or the lack of regard for others' rights is more characteristic of personality disorders, especially antisocial personality disorder. And I want you to keep in mind that anxiety can sometimes lead to irritability or anger. The antisocial tendencies described here are not commonly associated with anxiety disorders. So people with anxiety disorders may withdraw or become more passive, not typically act on antisocial ways. Now, I want you to pay attention to the keywords focusing on the worrying, excessive worry, regression, physical symptoms, and redirecting anxiety. Okay, these are all clues that directly relate to anxiety disorders. And I want you to look for the defense mechanisms, knowing that anxiety disorders often involves coping strategies like regression and displacement can help you guide to the correct answers. All right, so these defense mechanisms are ways the individual can deal with an overwhelming anxiety. Number 18, a client is prescribed isoniazid as a preventive treatment after their spouse is diagnosed with active tuberculosis. Which client statements suggest a need for additional education? Select all that apply. A, our children sometimes sleep in bed with us at night. B, I'll avoid drinking wine, but I can still have a cheese at a friend's gathering. C, I'm planning to start taking vitamin B6 with my morning meal. D, since my skin test was positive, I know I also have tuberculosis. And E, I understand that I will still be taking this medication 6 months from now. Now, this question is about educating a client who is on isoniazid as a preventive treatment for tuberculosis. And it's asking you to identify statements that indicate a need for additional education. So you'll want to focus on misunderstandings about the medication or the disease process. You also need to look for the warning signs or common side effects, adverse effects associated with isoniazid treatment, as well as any misconceptions about the TB transmission or prevention. And so the keywords here are avoid, skin test, children. I'm talking about the overall words that you can find in the choices and also the question itself. Now, what are the correct answers here? One of those is letter A. We also have B and D. And why is letter A correct? Now, since the client's spouse has active TB, the children are at an increased risk for exposure and should be screened for TB as well. Even though the client is receiving INH for prevention, the spouse's TB can still pose a risk, especially for household members. So close contact, like sleeping in the same bed, is very concerning. And the family member should be educated on the risk and need for screening. Letter B is also correct. This is a critical misunderstanding. So both wine and aged cheese contain substances like tyramine and histamine, which can interact with isoniazid. I want you to take note of this. Wine, aged cheese contains tyramine and histamine, which can interact with the isoniazid. So it can potentially lead to headaches, flushing, and a drop in the blood pressure. And these foods should both be avoided while the patient is taking isoniazid, not just wine. And so this is a safety issue, and so this statement needs additional education. Letter D is also a correct option here. A positive skin test only indicates that the person has been exposed to TB and developed antibodies. It does not confirm active TB. And we know that additional diagnostic tests such as X-ray or sputum tests are needed to determine if the client actually has active TB or just a latent infection. So the client's understanding is incorrect here and needs further clarification. Now we're going to go into the incorrect options here, such as letter C. Why is letter C incorrect? Well, yes. This is supposed to be discarded because the statement itself is reflecting understanding. It does not indicate a need for additional education. Make sure you to recall that vitamin B6, which is the pyridoxine, is often given to prevent neuritis, which is a side effect of the isoniazid. And the nurse should educate the client to take it as prescribed, ideally with a morning meal, which is a standard recommendation. So this statement shows proper understanding of the medication's needs. Letter E, another incorrect option, because the statement also reflects understanding. It does not require further education. Take note that the isoniazid is typically taken for 6 to 12 months as part of the preventive therapy for latent TB. And the client should be informed that the length of treatment can vary depending on individual circumstances, but 6 months is typically for preventive therapy, and this shows a good understanding of the treatment regimen. So your critical strategy here is to focus on statements that reflect misunderstanding, anything that will require a need for further education, or statements that reflect misconceptions about the medication or the disease process itself. Let's have number 19. A nurse is assessing a client with kidney failure for signs of metabolic acidosis. What is the underlying cause of this acid-base imbalance in clients with kidney disease? A. Impaired filtration in the glomeruli leads to sodium and waste product retention. B. Buildup of metabolic waste suppresses breathing, causing carbon dioxide accumulation. And C. The renal tubules fail to reabsorb water, leading to highly concentrated acidic blood. And D. The renal tubules are unable to eliminate hydrogen ions and retain bicarbonate. The answer is what? I'm going to keep it a secret for now. Well, let's break down the question here. So, in this case, you're being asked to identify the underlying cause of metabolic acidosis in clients with kidney failure. So, you have to pay attention to key terms like kidney failure, acid-base imbalance, and also metabolic acidosis. So, this is a pathophysiology question. So, you have to know how the kidney function relates to the body's acid-base balance. It is very crucial here. So what you need to do here is to look for phrases related to kidney functions like filtration, hydrogen ion elimination, and bicarbonate retention. So these are the processes directly involved in acid-base regulation. And you need to eliminate answer choices that discuss unrelated aspects like fluid balance or respiratory changes, because those are not the primary cause of metabolic acidosis in kidney failure. And so the answer here is letter D, because in kidney failure, the kidneys lose their ability to function properly, particularly in the renal tubules. Now, I want you to recall that normally the renal tubules help to eliminate excess hydrogen ions, which are acidic, and they also work in retaining bicarbonate, which is alkaline. Now, when the kidney function is impaired, hydrogen ions accumulate in the blood and there is a loss of bicarbonate. And this results in metabolic acidosis, where the body's pH drops, making it more acidic. Now, why are letters A, B, and C incorrect? Let's start with letter A. We know that it's true when kidney failure results in impaired filtration, it can lead to sodium and waste product retention, but this is not the primary cause of metabolic acidosis. The answer is focused more on fluid and waste retention. Okay, this is not on the acid-base regulation, which is the key issue in the metabolic acidosis. So the sodium retention leads to fluid balance issues, but it does not directly cause acidosis. Letter B, another incorrect option here, because this option refers more to respiratory acidosis, not metabolic acidosis. While it's true that a buildup of waste products like urea can occur in kidney failure, this would not directly suppress breathing to cause carbon dioxide accumulation. Now, I want you to remember, in metabolic acidosis, the respiratory rate usually increases to help exhale carbon dioxide and compensate for the low pH in the blood. So this answer is incorrect. It linking to acidosis or the respiratory issues. Now, letter C, another incorrect option here. This option confuses fluid balance with acid-base balance. While kidney failure can affect the kidney's ability to reabsorb water, which leads to fluid imbalances, this option doesn't directly cause acidosis. Now, the acidic blood, rather, in metabolic acidosis can result from the inability of the kidneys to eliminate hydrogen ions and retain bicarbonate, not from an issue with water reabsorption. Okay, so key strategies for you to use in this question is to recall the key physiology and also to focus on the right organ and process. The kidneys are the primary organs involved in maintaining acid-base balance by managing hydrogen ions and bicarbonate. And also you got to be cautious with distractors. Answer choices that mention respiratory changes or fluid balance can be distracting. All right, let's have number 20. A client sustains a functional spinal cord transection at the C7, C8 level and develops spinal shock. What assessment findings should the nurse expect in the immediate post-injury period? Select all that apply. A. Loss of muscle tone and movement. B. Involuntary loss of bladder and bowel control. C. Impaired respiratory function. D. Muscle spasms and rigidity. E. Absence of reflex activity below the injury site. Now, this question is asking about the assessment findings expected in spinal shock after a spinal cord injury at the C7, C8 level. And the key here is to recognize that spinal shock is a temporary condition that happens immediately after the injury, and it can affect the reflexes, the muscle tone, and autonomic function below the injury site. Now, the critical test-taking strategies for you to use is to focus on the immediate post-injury findings and the flaccid paralysis that occurs with spinal shock. Again, take a look into the word spinal shock. Understanding the timeline, 48 hours to several weeks, which can help clarify which symptoms are expected. Now, another thing that you need to consider is the spinal level. We are talking about C7, C8. This is very important for understanding the neurological function that may be involved, such as motor function, autonomic functions like bladder and bowel control. And I want you to also distinguish between acute spinal shock and recovery phases. So this question asks specifically about the findings immediately after the injury. So you'll need that, you need to avoid those answers that describe changes occurring later in the recovery phase, like muscle spasms or more complex autonomic responses. And so the correct answers here are letters A and E. And why letter A? This is a classic feature of spinal shock because immediately following the spinal cord injury, the muscles below the injury sites are flaccid. It means there's going to be no tone and there is no voluntary movement. Now, this lack of muscle function is due to the loss of reflex activity below the level of the injury, and it is a hallmark of spinal shock. And the condition can last up to several weeks before spasticity or muscle tone begins to return. Again, that's the key right there. The condition can last up to several weeks before muscle tone begins to return. Now, letter E, one of the correct options here. It's because during the spinal shock, the reflexes below the injury site are completely absent. And this happens due to the disruption in the communication between the brain and the spinal cord. Now, the reflexes like the deep tendon reflexes will not be present, and this condition can persist until the shock resolves and reflexes gradually return. Now, let's focus into the incorrect options here, such as muscle spasms and rigidity. Yeah, the muscle spasms and rigidity are not part of the spinal shock phase. These symptoms are more likely to develop after spinal shock has subsided. And we're talking about spastic phase of recovery. Now, I want you to, again, remember that in the acute phase, the muscles are flaccid, not rigid, or not spastic. So this answer describes a later stage of recovery, not the immediate post-injury period. Letter B is also incorrect, involuntary loss of bladder and bowel control, because during the acute phase of spinal shock, the bladder and bowel typically experience retention, not incontinence. Okay, so this statement right here, involuntary loss of bladder and bowel control, is basically referring to incontinence. All right, so again, during the acute phase of the spinal shock, the bladder and the bowel typically experience retention, not incontinence. And this is happening because the autonomic control over this system is disrupted. And I want you to recall that incontinence occurs more often after the spinal shock phase has resolved, when spasticity or autonomic dysreflexia might cause issues with bladder or bowel control. Now, during the acute phase, the problem is usually retention, not involuntary loss. Letter C, another incorrect option, it's because respiratory function would be affected only if the injury is at the C4 level or higher. And in this case, the injury is at level C7, C8, which is below the phrenic nerve, C3, C5, that controls the diaphragm. And recall that the respiratory system would be less affected in this C7, C8 injury because the phrenic nerve and its ability to stimulate the diaphragm remains intact. And so this option is incorrect. Now, for you to strategize in answering correctly this question, I want you to focus on the timing. The question again is asking for the findings in the immediate post-injury period. So avoid answers that describe recovery phases like muscle spasms, incontinence, or impaired respiratory functions, except at higher injury levels. And you also need to keep the phrases, look for the phrases spinal shock. Okay, you have to expect flaccid paralysis and absence of reflexes. Let's have number 21. A newly diagnosed client with conversion disorder presents with leg paralysis. What is the nurse likely to observe regarding this client's condition? A, the client will regain function in the affected leg but may experience similar symptoms under stress in the future. B, the paralysis will spread to other areas of the body. C, ongoing psychiatric treatment will be necessary for the client to maintain independent living. And D, the emotional course of the disorder will remain unpredictable depending on stress levels. Now, this question is asking you about conversion disorder and the nurse's observation of a client with leg paralysis related to this condition. And the most critical thing to focus in this question is understanding that conversion disorder is a psychological condition where emotional stress or trauma manifest as physical symptoms like paralysis that do not have a clear medical cause. Now, your key test-taking strategies to use here will be the conversion disorder in itself. This is a psychological condition where stress or emotional distress manifests as physical symptoms. Now, the symptoms that are going to be seen are going to be temporary, and the condition follows a pattern of stress-induced episodes. Now, what you're going to do next here is to focus on the course of the disorder. We know that conversion disorder symptoms can improve when the symptom or when the stressor rather is managed, but they can return with future stress. So you need to anticipate answers that reflect this pattern. Now, another strategy for you to do is to rule out physiological conditions, because the disorder is psychological, not neurological. So you can eliminate answers that suggest progressive physical deterioration, such as spreading paralysis or requiring lifelong treatment. Again, the words lifelong treatment. All right, take note of those. Now, what is the answer of this question? The correct answer here is letter A, because in conversion disorder, symptoms like paralysis may appear suddenly and be temporary, and the individual may regain function in the affected body part, and the paralysis is often linked to emotional distress. Now, the symptoms might reappear in the future during periods of stress, as they are triggered by psychological factors rather than physical injury or disease. So this is a typical pattern of for the conversion disorder. The symptoms are often situational and, again, stress induced, and they may resolve when the stressor is dealt with or it's resolved itself. Now, what about the other options here? B, C, D. Why is letter B incorrect? The paralysis will spread to other areas of the body. This is not typical of conversion disorder, because the symptoms in conversion disorder are often localized to a specific body part, such as a leg or arm, and do not typically spread to the other areas or the opposite extremity. Again, the condition is linked to psychological distress, is not associated with progressive neurological conditions. So paralysis usually does not spread to other body parts. It tends to remain in the initially affected area. Letter C, another incorrect option here. We know that psychotherapy such as cognitive behavioral therapy can be beneficial. It's not typically required for lifelong management. Take note of the word that makes it incorrect. All right. Now, another thing, we have letter D. Emotional course of the disorder will remain unpredictable depending on stress levels. Why is this incorrect? Because the emotional course of the conversion disorder tends to be predictable in terms of symptom re-emergence. And symptoms tend to flare up when the individual is under significant stress. While the emotional response can vary, the recurrence of symptoms follows a pattern and usually triggered by stress. So it's not completely unpredictable. There's a pattern based on stress. Now, I want you to recognize the psychological basis about this question. You have to focus on the fact that conversion disorder is a psychological condition. All right. And you also need to catch on the term temporary stress-related symptoms. All right. Temporary paralysis. And also to expect symptom resolutions, because symptoms in conversion disorder often resolve or they will improve when the stressor is addressed. So you got to be cautious of answers that suggest lifelong or continuous treatment. Number 22. While caring for a patient undergoing peritoneal dialysis, which observation should prompt immediate action from the nurse? A, the patient passed 50 mL of urine throughout the day. B, the amount of dialysate returned is greater than the amount infused. C, the patient complains of abdominal fullness. And D, the dialysate return appears murky. Now, this question tests your skill on recognizing potential complications during peritoneal dialysis, which is a process where the dialysate fluid is infused into the abdomen and then drained out. Now, the nurse needs to identify which observation requires immediate action. Now, you have to look into the key terms. Immediate action. Look for the answer that indicates something is critical or potentially dangerous, especially infections, because they need to be addressed quickly. Now, you also need to focus on abnormal findings. While some responses may seem concerning, you have to focus on which one is an immediate threat. And so abnormal color changes or signs of infection are key to your clues here. And you also need to take on the dialysate clues. The condition of the dialysate fluid is essential in identifying complications like infections. Now, what is the answer to this question? The answer is letter D. A cloudy or murky dialysate is a key sign of infection in the peritoneal cavity, specifically peritonitis. This is an emergency situation because peritonitis can lead to serious complications. It can spread easily into the bloodstream, and immediate intervention, such as starting antibiotics or other treatments, will be required to prevent further harm. And so I want you to recall that a clear dialysate return is the expected in normal circumstances. And so whenever there's murkiness or if there's cloudiness of the dialysate, it signals infection and must be addressed right away. And so the other options, A, B, C, are incorrect. Let's start with letter A. Why is this incorrect? We know that the amount of urine is low. It's not uncommon for patients undergoing peritoneal dialysis, especially those with kidney failure or reduced kidney function. And so the key issue with peritoneal dialysis is the dialysate exchange, not the amount of urine, unless there's a dramatic change or a history of high urine output. This is not an immediate concern. Letter B is also incorrect. This is actually a normal occurrence because typically the amount of dialysate returned should be greater than what was infused because fluid is removed from the body during the dialysate process. So there should be more out than the instilled dialysate. Okay, so this return is affected by how much fluid in the kidneys are filtering and how much is left in the peritoneal cavity after the process. So this does not indicate a problem that requires immediate action. Letter C is also incorrect because the abdominal fullness is common and also expected symptom during the peritoneal dialysis, especially during the dwell phase. Okay, so the infusion of dialysate into the abdomen can cause some discomfort and a feeling of fullness. Now, I want you to remember that nurse should also monitor the client, and this symptom is not an indication of a complication that requires immediate action unless it is severe or accompanied by other signs like pain or, let's say, distension that is getting more so uncomfortable. So this would not warrant immediate action. Now, for you to correctly answer this question, you gotta focus on signs of infection. That's the key. That's the key here. Like the murky dialysate, that's one. Okay, it's a sign of infection that needs to be addressed immediately. Alrighty, we have number 23. The parents of an infant diagnosed with communicating hydrocephalus seek further clarification about their baby's condition. How should the nurse explain it? A, the spinal fluid does not drain properly from the brain cells into the spinal cord. B, the brain is producing an excessive amount of cerebrospinal fluid. C, a part of the brain that normally absorbs CSF is not working correctly. And D, a blockage in the brain's ventricles is preventing proper absorption of cerebrospinal fluid. Now, when you're tackling this type of question, the most important strategy is to focus on the specific type of hydrocephalus mentioned. And we are talking about communicating hydrocephalus, all right? That is the key here, which indicates a problem with CSF absorption, not with the production or the flow blockage. And so understanding this distinction is very critical in selecting the correct explanation. Now, again, the key word here is communicating. This suggests that the issue is with absorption of the CSF, which will help eliminate answers involving blockages or overproduction. You also need to recall about the pathophysiology of communicating hydrocephalus. And in this condition, the cerebrospinal fluid circulates properly, but is not absorbed into the bloodstream as it should be. It can lead to increased fluid accumulation in the brain. Now, the correct answer here is letter C. Okay? Because again, in communicating hydrocephalus, the problem lies with absorption of the CSF, not with the production, not with the flow. Again, the CSF is produced normally but cannot be absorbed into the bloodstream effectively. That's why it's causing buildup in the brain. And this typically occurs when the arachnoid villi responsible for the CSF absorption are damaged or not functioning properly. And so this answer accurately explains the underlying pathophysiology of communicating hydrocephalus. Now, what about letter A? Why is this incorrect? Because it inaccurately describes the mechanism of hydrocephalus. Take note that the CSF does not drain from brain cells into the spinal cord. It rather circulates through the ventricles in the brain and around the spinal cord. And so communicating hydrocephalus is related to absorption issues, not drainage problems. So this explanation doesn't apply. Letter B is also incorrect because this describes a condition called choroid plexus tumor, wherein there is an overproduction of the CSF, but it does not apply to communicating hydrocephalus. Again, in communicating hydrocephalus, CSF is produced normally, but the issue is with the absorption. Letter D is also incorrect because this describes non-communicating hydrocephalus where there is a blockage in the brain's ventricles that prevents the proper flow of CSF. And in contradiction, communicating hydrocephalus occurs when CSF can flow freely between the ventricles, but cannot be absorbed properly into the bloodstream. So this answer reflects the wrong type of hydrocephalus. So I want you to focus into the clue communicating, okay? That's the clue in answering this question. You also need to eliminate those answers related to blockage or overproduction of the CSF. 24. A pregnant woman in the prenatal clinic mentions that she is taking a folic acid supplement and asks which naturally folate-rich foods should add to her diet. Which foods should the nurse suggest? Select all that apply. A, fortified bread and pasta. B, chicken and turkey. C, milk and cheese. D, black and pinto beans. E, beef and fish. Now, when answering this question, the most important strategy is to focus on the word folate and also to identify food items that are naturally high in folate or food items that are enriched or fortified with it. Now, folate is a B vitamin, and many foods are either naturally rich in folate or are fortified with it. Now, the key clues in the question are the word naturally, meaning foods that contain folate in their natural form, not through fortification, and folate-rich foods. Now, your key focus here would be to look into the food items that are either naturally rich in folate, like legumes, and also food items that are fortified with folate or enriched during the processing. Now, the answers are letters A and D. And why letter A? We know that these are not naturally high in folate, but they are often fortified with folic acid, which is the synthetic form of folate during processing. And the US has a policy of fortifying many grain products to help prevent neural tube defects in pregnancies. So this is a great recommendation for folate intake. What about letter D? Well, black and pinto beans are an excellent natural source of folate. Legumes, including beans, lentils, and peas, are rich in this vitamins and should definitely be included in a folate-rich diet, especially during a pregnancy. And this makes the beans an excellent source. Now, why is chicken and turkey incorrect? Well, we know that they are good sources of protein. Now, They do not contain a significant amount of folate. Poultry is not a good source of folate, so it wouldn't be the best recommendation for increasing folate intake. What about letter C? Dairy products like milk and cheese are important for calcium and vitamin D, but they are not rich in folate. While they are nutritious, they don't really provide the necessary folate levels required during pregnancy. And we have letter E, which composes beef and fish. Just like the poultry, beef and fish are also excellent sources of protein and iron, but are not significant sources of folate. Even though they offer other nutrients, they are not rich in folate and should not be emphasized for increasing folate intake. So for you to answer this question correctly, you need to look for the key nutrients, specifically folate-rich foods, and focus on foods that are naturally high in folate, like legumes, and also fortified grain products. Now, 25. A 20-year-old male college student is brought to the mental health clinic by his parents and diagnosed with borderline personality disorder. Which aspects of his history support this diagnosis? Select all that apply. A. Frequent mood swings. B. Self-harming tendencies. C. Lack of impulse control. D. Slowed physical movements. And E. Repetitive behaviors. Now, to answer this question, it's very important for you to focus on the key behaviors that are characteristic of borderline personality disorder, or BPD. And I want you to recall that BPD is marked by instability in relationships, self-image, and also emotions. So the test will likely include options that either align with this instability or don't. So look for impulsivity, and also emotional extremes, and maybe self-destructive behaviors, which are hallmarks of the BPD. Now, the correct answers here are the following. We have letters A, B, and C. Why letter A? That's because mood swings or lability in mood are a classic symptom of borderline personality disorders. And individuals with a BPD often experience intense emotions that can shift rapidly, sometimes within the same day. And these mood swings are linked to instability in emotions, which is one of the hallmark features of the BPD. And this could include anger, sadness, and irritability. And so there's rapid shifting of the mood all throughout the day. What about letter B? Well, self-harm, like cutting, burning, or other forms of self-injury, is commonly seen in borderline personality disorder. And this behavior is often used as a way to cope with overwhelming emotions, or a way to feel in control when there is a sense of emptiness or emotional numbness. It is a significant feature in the diagnosis of BPD as well. Now, letter C, lack of impulse control. Again, impulsivity is another key feature of the BPD, and the people affected with this disorder often struggle with controlling their impulses, which can lead to reckless or self-destructive behavior, such as unsafe sex, or maybe substance abuse or gambling. And so this behavior contributes to the instability that defines the BPD. Now, what about the other options here? Such as letter D, slowed physical movements. This is incorrect because slowing of physical movements are not typically associated with a BPD, but instead they are more commonly seen in mood disorders like depression, where psychomotor slowing can occur. And BPD is more characterized by emotional volatility and impulsive actions, not slow or inhibited psychosocial or physical movements. Now, letter E is also incorrect here because repetitive behaviors are more characteristic of obsessive compulsive disorder rather than the BPD, while individuals with the BPD may have issues with compulsive behaviors in some cases, but repetitive behaviors like compulsive checking of locks or washing hands repeatedly are specific to OCD, not BPD. So I want you to use the critical test-taking strategy in answering this question. I want you to recall the key features of BPD. There is instability in emotions, there is impulsivity, and self-destructive behaviors. And I want you to eliminate non-BPD traits, okay? And so this could be slowed physical movements and repetitive behaviors. These are more closely related to depression or OCD. Alrighty, now you have completed the first part of the 3 sections here. Again, we are inviting you to enroll section number 26. When caring for a client in the transition phase of the first stage of labor, which approach should the nurse use to guide her care? A. Assist the client in maintaining a sense of control. B. Alleviate discomfort by administering pain medications. C. Encourage the use of simple breathing techniques during contractions. And D. Reduce the rate of IV fluids. Now, when you're approaching a question about labor and delivery, you need to focus on the phase of labor and the specific needs of the client during that phase. Now, for the transition phase of the first stage of labor, the key characteristics include intense contractions, emotional changes, and also the need for reassurance and support. And this phase can be overwhelming for the client. So the nurse's role is to provide guidance that helps the client manage discomfort, to maintain control, and also to prepare for the next phase of labor. Now, I want you to look for the clues, okay, to look for answers that align with providing emotional support, helping the client, and also managing intense emotions and ensuring the safety of the newborn. And so the correct answer here is letter A. Because during the transition phase, this is the most challenging part of the labor, where contractions become stronger and more frequent, and the client may experience emotional distress, fatigue, and anxiety. And during this phase, the client needs encouragement and support to help them cope with the physical and emotional demands of labor. And maintaining a sense of control is critical, as the client may feel overwhelmed by the intensity of the contractions. And this approach also allows the nurse to help the client feel empowered, supported, and also ready for the final stage of labor. Now, the other options here, such as letter B, we have letter B, alleviate discomfort by administering pain medications. This is incorrect for the reason that the pain medications such as epidurals or, let's say, systemic analgesics can depress the newborn's respiratory system and interfere with the baby's ability to initiate breathing immediately after birth. And during the transition phase, it's crucial to avoid interventions that may cause harm to the newborn. And so non-pharmacologic pain relief methods such as breathing techniques, position changes, and emotional support are more important at this time. Letter C is also incorrect because in the transition phase, the contractions are typically very intense and the client needs more complex breathing techniques to manage the pain and to stay focused. And so simple breathing techniques are more helpful in early labor, while more advanced breathing strategies like pattern breathing are often introduced during the transition phase to help the client focus and also to manage the intensity of the contractions. Letter D is also incorrect because during the transition phase, metabolism increases and the body's demand for fluids goes up due to the intensity of the labor process. And so IV fluids are essential to maintain hydration and electrolyte balance. especially since dehydration can cause complications. In fact, increasing the rate of IV fluids may be necessary rather than reducing it. And so this ensures that the client remains well hydrated, which helps with uterine contractions and overall labor progression. So you need to understand the phase of the labor in order for you to answer this question correctly. And again, recall that transition phase involves intense contractions, emotional volatility, and the need for reassurance. And you need to focus on answers that offer support and guidance to help the client cope with this challenging phase. Let's have number 27. When evaluating a client with Parkinson's disease, which clinical manifestations should the nurse anticipate? Select all that apply. A, loss of muscle tone. B, reduced facial expression. C, slowed voluntary movements. D, tremors while at rest. And E, generalized tonic-clonic seizures. Now, when you are approaching a question about Parkinson's disease, focus on the classic symptoms and understand pathophysiology, right? And so I just want to reiterate here that Parkinson's disease primarily affects the basal ganglia and substantia nigra, leading to the disruptions in motor control. And so you need to pay attention to key phrases in the questions like clinical manifestations and which symptoms should the nurse anticipate, because these will direct you to focus on the expected symptoms based on the disorder's pathophysiology. So you need to look for symptoms associated with rigidity, tremors, slowness of movement, and exclude options that describe symptoms unrelated to the conditions, such as seizures. Now, for the correct answers here, we have letters B, D, and C. And why letter B? This is a common feature of Parkinson's disease, and that is the flat affect. And this is often described as a mask-like appearance. And this is due to the degeneration of the neurons in the basal ganglia and substantia nigra, where there's a reduced ability to move facial muscles, which leads to a decreased facial expression. And this can manifest as unblinking eyes and also a lack of emotional expression, which is a hallmark of Parkinson's disease. Letter D, tremors while at rest, is also one of the hallmark symptoms. And these tremors typically occur when the body is at rest and are often described as a pill rolling movement, where the thumb and fingers move in a circular motion. And this occurs due to the dopamine deficiency in the brain, affecting the control of voluntary movements. We have also letter C. This is what we call as bradykinesia, or slowed voluntary movements. And this is another key symptom of Parkinson's disease. And this is caused by the dysfunction of the basal ganglia, which plays a major role in coordinating and initiating movement. Now, what about letter A, loss of muscle tone? Well, Parkinson's disease is not characterized by muscle flaccidity, or what we call as muscle tone. Instead, muscle rigidity is a key symptom, and this is the result of sustained muscle contractions, which lead to jerky, stiff movements, often described as cogwheel rigidity. And the muscle tone is increased, not lost in Parkinson's disease. Now, letter E. Generalized tonic-clonic seizures are not a typical manifestation of Parkinson's disease. And the Parkinson's primarily affects motor control, leading to tremors. There's going to be a rigidity, bradykinesia, but does not typically cause seizures. And I just want to remind you that seizures may occur in some individuals due to other neurological conditions, but they are not directly related to Parkinson's disease. So I want you to understand and recall the hallmark symptoms of Parkinson's disease, that it causes motor-related symptoms, including tremors at rest, rigidity, and slowed voluntary movement. Let's have number 28. A client with type 1 diabetes asks the nurse why they become dehydrated when their glucose level rises. What is the nurse's best response? A. The high glucose level draws water from your tissues into the bloodstream. B. You get thirsty with high glucose, which leads to dehydration. C. Sweating from the elevated glucose levels causes dehydration. And letter D. Your kidneys cannot filter the urine properly, causing dehydration. Now, when answering questions related to diabetes and dehydration, it's essential to connect the physiology of glucose and fluid balance. So I want you to look for the keywords in the questions like high glucose, dehydration. So this will guide you to the pathophysiology of hyperglycemia in type 1 diabetes and how it leads to dehydration. So you need to watch for answers that relate to osmotic diuresis, as this directly explains why high glucose levels lead to fluid shifting and dehydration. Now, the answer here is letter A. Well, when the blood glucose levels rise, so when there's going to be hyperglycemia, especially in type 1 diabetes, the blood becomes hyperosmolar. It means it has a higher concentration of solutes, and in this case, glucose. And to balance the osmolarity, water moves from the tissues or the extracellular space into the bloodstream. And this results in dehydration because the fluid shifts out from the tissues and into the blood, making the body less hydrated. Now, letter B is incorrect option here. So let's go back into B. You get thirsty with high glucose, which leads to dehydration. Is that correct? Well, while thirst is indeed a common symptom of dehydration, it is a consequence, not a cause. And thirst is the body's response to the dehydration, but it doesn't explain why dehydration happens in the first place. Now, the underlying cause is the osmotic effect of the high glucose levels drawing fluid from the tissues, as explained in letter A. Letter C is also incorrect because sweating is more commonly associated with hypoglycemia, not hyperglycemia. Take note that in hyperglycemia, the body doesn't sweat more. It increases urination or polyuria as a response to the excess glucose in the blood. So this explanation doesn't really match the physiologic process in hyperglycemia. D is also incorrect. We know that kidney function is indeed involved in the process. The primary cause of dehydration in this case is osmotic diuresis, not an inability to filter urine. Now, I want you to recall that in hyperglycemia, the kidneys try to filter excess glucose out of the body, or the blood rather, by excreting it into the urine. But the high glucose levels draw water along with it. And so this results in frequent urination and dehydration. But the issue is not due to improper filtration. It's the result of the osmotic pressure from the high glucose levels. So for you to answer this question, you need to recall the underlying physiology, especially the dehydration in diabetes, and of course with the corresponding osmotic diuretic effect. Let's have number 29. Which of the following clients is most at risk for developing acute kidney failure? A, a client who received an autologous blood transfusion. B, a client with essential hypertension. C, a client with type 2 diabetes. And D, a client who experienced an anaphylactic reaction. Now, I want you to focus about what is being asked here. It's about development of acute kidney failure. So you need to identify those conditions or events that can cause sudden or, let's say, severe reduction in kidney perfusion or damage to the kidney tissue in a very rapid manner. And so I want you to look for clues in the question that point to causes of ischemia or, let's say, lack of blood flow or direct renal injury, as these are primary contributors to acute kidney failure. Now, what is the answer here? The answer is letter D. because an anaphylaxis involves a severe allergic reaction that can lead to circulatory collapse. Now, during this crisis, the blood pressure drops drastically, which can reduce the renal blood flow to the kidneys. And without the adequate perfusion, the kidneys are at risk to develop acute kidney injury or failure due to the ischemia. And so that's why this answer correctly identifies a critical event that significantly increases the risk of AKI. Now, the rest of the answers here, such as letter A, well, a client who received an autologous blood transfusion, well, what's really happening here is that when they do that, they typically are receiving their own blood. Typically, the blood is collected before the surgery. And since the blood is the client's own, it poses minimal risk of causing complications like acute kidney failure. And this is a safe procedure, and it's unlikely to lead to kidney damage. Now, what about letter B here? A client with essential hypertension. We know that essential hypertension, or let's say chronic high blood pressure, can damage the kidneys over time. It is more commonly associated with chronic kidney disease rather than acute kidney failure. And the kidneys can compensate for elevated pressure for years, but chronic high blood pressure can eventually cause nephrosclerosis. There's going to be scarring of the kidneys and chronic renal failure, not an acute event. Now, letter C. This is also incorrect because type 2 diabetes is a risk factor for chronic kidney disease, particularly when blood glucose levels are poorly controlled over time. However, it's not typically a direct cause of acute kidney failure because chronic hyperglycemia can damage the kidneys gradually, leading to diabetic nephropathy, but this doesn't directly cause an acute drop in the kidney function. So what I want you to do in answering this question, you need to focus on the events that lead to acute kidney injury, right? So it's crucial to identify the conditions that can cause a sudden loss of kidney functions like severe dehydration, circulatory collapse, or anaphylactic shock. Let's have number 30. A client who is severely depressed has consented to electroconvulsive therapy or ECT, but continues to express concerns and anxiety about the procedure. What should the nurse focus on emphasizing when discussing ECT with a client? A, you won't be left by yourself during the procedure. B, you might experience a headache during the procedure. C, the procedure should help you feel better. D, you may have episodes of memory loss after the procedure. Now, this question is focusing on therapeutic communication and prioritization of emotional support. And the client is already anxious about ECT. So the best response here should to reduce anxiety and provide reassurance without offering false hope or emphasizing negative effects. So I want you to pay attention to the key word clues in the question. So there's that express concerns and anxiety. So the priority here is to ease anxiety. Another here is nurse focus. Okay, so this means the answer should align with the therapeutic role of the nurse, which includes support and reassurance rather than detailed side effect explanations. So the answer here is letter A. And why is that? Because the client's anxiety is the primary concern in the case. And the best way to address it is through continuous emotional support. Now, knowing that staff will be present throughout the procedure can provide reassurance and helps the client feel safe. And this also aligns with the therapeutic communication because it validates the client's concerns without increasing fear or providing false reassurance. Now, what about letter B? This is an incorrect option. We know that headaches can occur after electroconvulsive therapy, but they don't happen during the procedure since the client is under anesthesia. Also, while acknowledging possible side effects is important, it does not directly address the client's anxiety. So the better approach here is when the client asks about the side effects, the nurse should mention that any discomfort can be managed, maybe with the use of analgesics for headaches. Now, what about letter C? This is also wrong because this is false reassurance. We know that ECT is effective for many clients, but there is no guarantee that it will work for the specific individual. Now, a therapeutic response should validate the client's feelings instead of making unrealistic promises. Now, for letter D, one of the incorrect options here, this statement focuses too much on a possible negative effect, which could increase the client's fear instead of reducing their anxiety. And we know that temporary memory loss is a known side effect, but it's not the most relevant concern at this moment when the client is feeling anxious about procedure itself. So my strategy for you to use when you answer this question, you need to always choose an answer that helps ease anxiety without false reassurance, because therapeutic communication is key. You need to also look for the client's emotional state in the question. The phrase expresses concerns and anxiety tells you that providing comfort is the priority. And I want you to avoid those answers that emphasize negative effects like memory loss or make unrealistic promises like this will make you feel better. And also, safety and support are always key, always the top priorities in psychiatric nursing. And in this case, ensuring the client won't be alone during the ECT. And that is the best response. Let's have number 31. After a cleft lip repair surgery, what should the nurse include in the care plan for an infant? A, feed with a spoon for 2 days following surgery. B, prevent any crying. C, keep the infant NPO for the first 24 hours post-surgery. And D, position the infant in semi-fowlers. Now, this is a question that is about post-op care for an infant after a cleft lip repair, or known as chyloplasty. And the key focus is on protecting the surgical site and promoting healing. So you need to focus on clues such as the words after a cleft lip repair, surgery. This tells you the focus is on post-op care, and the words care plan for an infant. This means you need to choose an answer that ensures safety, healing, and comfort for this infant. Now, what is the correct answer here? The answer is letter B. It's because the crying increases tension on the suture line, which can lead to wound dehiscence or opening of the surgical site, and also poor healing. Now, you also need to anticipate. The nurses here should anticipate the infant's needs, such as feeding, diaper changes, and comfort. These are known causes why they're going to cry. And you need to make sure that these are met before the child starts crying. And so some other protective measures such as arm restraints like no-no splints, metal appliances, or adhesive strips are also used to minimize trauma to the surgical site. Now, why is letter A incorrect here? It's because a spoon is not used after a cleft lip surgery because it may damage the sutures. Now, a better feeding method would be to use a rubber-tipped syringe, or let's say a dropper, or maybe special cleft lip feeder, and this is recommended to reduce the stress on the surgical site while ensuring proper nutrition. Now, letter C is also incorrect because infants do not need to be NPO for 24 hours after the cleft lip repair, and early feeding is encouraged typically within 6 hours post-op, using small frequent feedings with an appropriate feeding device. Now, I want you to pay attention that prolonged NPO status could lead to dehydration, also hypoglycemia, and increased irritability, which increases crying, which we want to prevent. Letter D, is also incorrect because it's not really necessary for a cleft lip repair after. And so the infant can be placed on their back or let's say side, of course, with monitoring to prevent pressure on the lip. Now, I want you to look for the answers that protect the surgical site. And the biggest risk after the cleft lip repair is wound, tension, and dehiscence. And I want to emphasize this one more time. Crying is the #1 thing to prevent because it puts stress on the sutures. All right. So I want also to eliminate the answers that introduce unnecessary risks like feeding with a spoon or keeping the baby NPO. And also recall about the best positioning. It should be either back or the side, not semi-Fowlers. 32. During labor, a prima gravida at 7 centimeters dilation is given a prescribed pain medication. Which medication requires that the newborn be monitored for respiratory depression after delivery? A. Diphenhydramine, B. Promethazine, C. Hydroxyzine, and D. Butorphanol. This question is all about the pain management during labor and its effects on the newborn. And the key focus here is identifying which medication can cause respiratory depression in the baby after delivery. Now, the key word clues here are during labor. This tells you the focus is on maternal pain relief. And also the 7 centimeter dilation. This means that the client is in active labor and approaching transition phase. And so the baby may be born sooner. And so newborn may be monitored for respiratory depression. That's another keyword, another set of keywords right there. So the correct answer must be a medication that can cross the placenta and depress neonatal breathing. And so there's no other answer here other than letter D. That's the butorphanol or Statal. This is an opioid agonist antagonist analgesic that is used for moderate to severe pain during labor. And take note that opioids cross the placenta and can cause respiratory depression in the newborn, especially if given close to delivery within 3 to 4 hours. Now, because the half-life of butorphanol is short, newborns exposed to it late in the labor need careful respiratory monitoring after the birth. And if severe neonatal respiratory depression occurs, the naloxone or Narcan may be needed to reverse the effects. Now, why is letter A incorrect? Well, this is antihistamine, right? It's not an opioid. It doesn't cause neonatal respiratory depression, but it can make the mother drowsy and help with anxiety. The same with promethazine in B. It's also antihistamine, which is used for nausea and sedation in labor. And it may also cause maternal sedation, but it does not significantly depress neonatal respiration. Sometimes given with opioids to enhance pain relief, but not the cause of neonatal respiratory depression itself. Now, letter C, another incorrect option. This is another antihistamine similar to Phenergan. It's used for anxiety and nausea during labor, but it does not suppress neonatal breathing like opioids do. So, final takeaways here. I need you to recall that opioids are the major concern for neonatal respiratory depression, and that's why we have the Statal or the butorphanol as the best answer here. Okay, let's have number 33. After frequent inner ear infections, a 3-year-old is scheduled for myringotomy with tube placement. What discharge instructions should the nurse provide to the family? A. Ensure the child uses earplugs during bath time. C or B. Clean the inner ear with cotton swabs. C. Keep the child home from daycare for 1 week. And D. Apply ear ointment daily. So this question is focused on post-op care following myringotomy with tube placement in a 3-year-old child. And the goal for this question is to identify the most appropriate instructions that would help prevent complications, particularly infections after the procedure. And this is testing your knowledge on proper ear care and the prevention of infection in children who have had ear tube placement. And so the correct answer here is letter A. And why? Because the tubes create an opening into the middle ear, making it easier for water to enter and introduce bacteria. And take note that water exposure creates a risk of infection. So wearing earplugs or the headband while bathing or swimming is very important. Now, why is B incorrect? Well, the cotton swab should never be inserted into the ear canal, as they can push debris deeper, damages the tube, and even injure the eardrum. So what should the parents do here instead is to gently wipe the outer ear with a damp cloth. For letter C, this is another incorrect option because the child does not need extended isolation after surgery. Most children can resume normal activities within a day or two unless they are experiencing pain or discomfort. Letter D, another incorrect option here because ointments are not necessary, and this can also clog the ear canal. It can prevent proper drainage, and the tubes help fluid drain naturally. So keeping the ears clean and dry is the priority. So in answering this question successfully, I want you to focus on the prevention. That is the main concern here, okay? That is the prevention, and also to avoid infection. So you need to look for an answer that relates to the protection. Now, let's have number 34. A nurse is providing care for a client diagnosed with a ureteral stone. Which nursing interventions are most essential? Select all that apply. A, monitoring the client's blood pressure. B, restricting fluid intake during nighttime hours. C, administering prescribed pain medication. D, tracking fluid intake and urine output. And E, filtering urine to collect any past stones. Now, I want you to focus into the key issue here. There is ureteral stone. And the goal here is to assess your understanding of the appropriate care to manage the pain, monitoring renal function, and encouraging the passage of the stone. And in this type of question, look for answer choices that directly address pain, monitoring of the kidney function, and again, promotion of stone passage. So the correct options here are these. We have letters C, D, and E. We know that ureteral stones cause severe pain, often referred to as the renal colic, which can be debilitating, and that's why pain management is a priority. So administering analgesics that are prescribed will help manage the pain and also provide relief for the client. What about letter D here? Tracking fluid intake and urine output. Well, it's important to assess the client's renal function and also to detect potential complications, let's say urinary obstruction caused by the sediment or the stone. And so it's also vital for evaluating whether the stone is being passed effectively, or maybe it's blocking into a narrow passageway. And this can help identify if the client needs additional intervention, such as more aggressive pain management or possibly surgical intervention. Letter E, another correct option here. It's because straining the urine is very critical to identify what possibly is causing this renal stones, and it will also help determine the composition. Okay, this will be sent to the lab for analysis to determine the composition of the stone, which is important for future prevention of stone formation. And so this can allow identification of the stone and helps guide future treatment, and also for recommendations in their diet. And so we have letter A as one of the incorrect options here. We know that blood pressure monitoring is important in some cases, but it's not directly related to the management of a ureteral stone. The primary focus is on pain relief, fluid monitoring, and facilitating stone passage, not blood pressure management, unless the client has other underlying conditions that require such attention. Letter B is another option that's to be discarded. It's not recommended in this case. Well, in fact, what we're supposed to do is to encourage adequate fluid intake to help promote the passage of the stone and also to dilute the urine, which may make it easier for the stone to pass naturally. Now, restricting fluids could hinder the process of stone passage, and this can increase the risk of further complications. So when you answer this questions, or this type of question, you need to focus on interventions that address, again, immediate priorities, such as managing the pain, monitoring the renal function, and promoting the passage of the stone. 35. A client underwent an above-the-knee amputation of the left leg following a motor vehicle accident. The healthcare provider has instructed the client to use crutches for mobility until the residual limb is ready for a prosthetic fitting. What should be the nurse's initial action? A. Introduce the client to another individual who is also using crutches. B. Demonstrate the swing-through technique for crutch walking. C. Provide an educational pamphlet about crutch use. And D. Assess whether the client has prior experience using crutches. Now, this question is about managing care for a client who has undergone an above-the-knee amputation and needs to use crutches until they can get a prosthetic. And the question is asking about the initial action the nurse should take to ensure the client is safe and comfortable while using crutches. And the focus is on assessing the client's needs and experience with crutches. Now, I want you to take this. There's going to be very critical strategy here, and you need to pay attention to the words initial action, prior experience. These are your best clues. And the question is asking what the nurse should do first. So this means that you want to gather information before starting any interventions like demonstrations or providing pamphlets. So I want you to pay attention to words like first, initial, and prior to help you identify the priority action in this case. Now, what is the answer? That is letter D. Why? Well, before jumping into teaching or demonstrating techniques, it's important to assess the client's experience with crutches. All right. If the client has used crutches before, they may already know the proper technique and the nurse can tailor their teaching accordingly. If the client has no experience, then a more thorough teaching approach will be needed. And this assessment helps guide the rest of the teaching process and can ensure it's individualized to the client's needs. Now, the incorrect options here include letter A, B, and C. Now, why letter A? We know that it can be helpful for the client to meet someone else who is using crutches. This is not the first priority. The nurse's initial focus should be on assessing the client's current abilities and comfort level with crutches rather than immediately introducing them to another person. We know that social support can be incorporated later once the nurse has assessed the client's needs and begun teaching. Letter B is also incorrect. Although demonstrating the crutch technique will eventually be important, it should not be done until the nurse has assessed the client's familiarity and comfort with crutches. If the client has prior experience, they may already be familiar with the swing-through technique, and the nurse may only need to provide minor adjustments. So initial assessments is the priority before moving into demonstration or teaching. Letter E is also incorrect. Providing a pamphlet is not the priority at this point. The nurse has to assess the client's experience first to tailor the education appropriately. And a pamphlet may be useful later, but it's not the first intervention to take place. Education should be personalized to ensure it meets the client's level of understanding. And so when approaching questions about client education, always prioritize assessment first, especially when the client's prior experience or comfort level is in question. And in this case, assessing whether the client has used crutches before helps guide the next steps in teaching, so this can ensure a more efficient and effective plan of care. 36. A nurse uses the CAGE screening test to assess the risk of alcoholism in an individual. Which question is part of the test? A. How often did you consume alcohol in the past year? B. Do you consider yourself a normal drinker? C. Have you ever felt guilty about your alcohol use? D. Are you able to stop drinking whenever you choose? This question is asking about the CAGE screening test, which is a quick tool used by nurses and other healthcare professionals to assess the risk of alcoholism in individuals. And the question wants to know which of the listed questions is part of the CAGE test. And again, this is an important screening tool for identifying possible alcohol-related problems in a patient. So the nurse must be familiar with the exact questions it asks. Now, the CAGE screening test for alcoholism contains 4 questions corresponding to the letters CAGE, C-A-G-E. Now, what is in letter C? The question here will be, have you ever felt you ought to cut down on your drinking? So C reflects, or it represents cutting down on drinking. Letter A in the CAGE is asking, have people annoyed you by criticizing your drinking? So A represents annoyed. And letter G, it's going to be a question of, have you ever felt bad or guilty about your drinking? So G corresponds to guilt. And letter E is going to be asked as, have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover? Okay. Now, I want you to look at clues in the wording of the question, specifically the mention of CAGE. So again, the key to answering this question lies on recognizing the CAGE components and remembering which question corresponds to G for guilt. So we have answer here for this item. It's letter C. So this is a direct match to the G in the CAGE, which stands for guilt. And one of the questions in the CAGE screening test is specifically about whether the person has ever felt guilty about their drinking. And this question is aimed at identifying the emotional consequences of alcohol use, which is a key sign of alcohol dependence or problems. Now, if a person feels guilty about their drinking, it could indicate that their alcohol use is interfering with their life in a very negative way. And so the rest of the options here, A, B, E, are all incorrect. Now for letter A, this question is part of the alcohol use disorders identification, or known as audit. And this is a different screening tool used to assess alcohol consumption patterns. Now, the audit alcohol tool focuses more on the quantity and the frequency of alcohol consumption, whereas the CAGE focuses more on behavioral and emotional cues related to alcohol use, such as guilt or the desire to cut down. Letter B is also incorrect because this question is part of the Michigan alcohol screening test, or known as MAST, M-A-S-T, not the CAGE test. Now, the MAST is a longer test with 26 questions, and that is also used to assess alcohol use, but is more comprehensive, and it covers a wider range of behaviors and attitudes toward alcohol. Now, the CAGE is shorter and more direct in its questions, specifically focusing on emotional and behavioral responses. Now, letter D is also incorrect here. This question is also part of the audit tool screening, and this includes question about the person's ability to control their drinking, which is aimed at identifying problematic alcohol use. And again, the CAGE test, on the other hand, asks about feelings of guilt, criticism from others, and physical signs like morning drinking. Let's have number 37 after this. So again, you're invited to enroll to the NCLEX course via StanCoast NCLEXcoaching.com. Number 37. A laboring client experiences contractions that occur every 2 to 3 minutes and last approximately 45 seconds. During the intervals between contractions, the nurse observes a fetal heart rate of 100 beats per minute on the internal monitor. What should the nurse do next? A. Inform the healthcare provider. B. Continue monitoring the maternal vital signs. C. Restart continuous fetal heart rate monitoring. And D. Record the fetal heart rate as a normal reaction to contractions. Now, this question asks what the nurse should do next to respond to a fetal heart rate of 100 beats per minute. So the nurse needs to recognize that this is an abnormal fetal heart rate and may indicate fetal distress, which requires immediate action. Now, I want you to look for the key terms in the questions, like the heart rate of 100 beats per minute. That is already considered bradycardia for this baby or the fetus, which should raise a red flag for possible fetal distress. Now, the expected fetal heart rate between contractions is between 110 and 160 beats per minute. So any fetal heart rate below 110 beats per minute is considered outside the normal range. And this should prompt the nurse to consider the next steps in ensuring the safety of both the mother and fetus. Now, what is the answer to the question? The answer is letter A. Because the fetal heart rate of 100 beats per minute is below the normal range, and it's considered bradycardia, and it indicates that the fetus is compromised, which could be due to insufficient oxygen, or any other fetal distress signs. Now, when bradycardia is observed, it requires prompt medical intervention, and the healthcare provider should be notified immediately and to maintain fetal well-being. All right. What about letter B? Why is letter B incorrect? We know that monitoring the maternal vital signs is important in any laboring client, but it is not the priority in this situation. The abnormal fetal heart rate is a sign of potential fetal distress, and the priority should focus on fetal well-being rather than the mother's vital signs at this moment. Okay, so you as a nurse should act promptly to address the fetal concern by notifying the healthcare provider. Letter C is also incorrect because the fetal heart rate monitoring is already in place, and the fetal heart rate has already been observed to be abnormal. There's already that data. Okay. Now, restarting the monitoring would waste valuable time that could be used to intervene. So the nurse should not delay interventions by simply monitoring again. Instead, immediate action is needed by informing the healthcare provider and taking further action or orders to assess and address the potential fetal compromise. Letter D is incorrect because the fetal heart rate of 100 beats per minute is already abnormal. And again, recording it as a normal could lead to delayed intervention. It can put the fetus at risk. And it's very important to recognize abnormal findings and act accordingly rather than dismissing them as part of the normal process. So your strategy here, especially in dealing with this type of question, especially with labor, You need to take note that fetal heart rate abnormalities such as bradycardia should never be ignored. And you should act quickly to assess the situation and notify the healthcare provider who can take further steps to ensure the fetus's safety. 38. What healthy snack options should the nurse recommend for the parents of a 2-year-old diagnosed with acute asthma? Select all that apply. A glass of cold milk. B, chopped vegetables. C, grapes. D, sliced apples. E, oatmeal cookies. And F, ice cream. This question is asking about healthy snack options for a 2-year-old diagnosed with acute asthma. And the goal is to recommend snacks that are safe, nutritious, and appropriate for a toddler with asthma while avoiding foods that could trigger asthma symptoms like bronchospasms or choking hazards. So I want you to focus on keywords like acute asthma, healthy snack, and safe for a 2-year-old. And the question hints at foods that could trigger bronchospasms or cause choking hazards. So any options that could aggravate asthma or pose a risk of choking should be eliminated first. And in addition, you got to be cautious about cold foods or drinks, which are mentioned in the rationale as potential triggers for bronchospasms. And so we have our answers here. Letters B and D. Why chopped vegetables? Well, they are excellent option for a toddler with asthma as long as they are cut into small manageable pieces, and they are also nutritious. They are rich in vitamins, can prevent constipation, which is important in toddlers, since they are not cold, they don't pose a risk of bronchospasms as well. Now, the other option here, sliced apples, are also a good snack choice for a toddler with asthma because they are easy to chew and handle. And they also provide excellent nutrition, especially fibers and vitamins, which are essential for toddlers. And like the chopped vegetables, apples are not cold and also do not pose a risk of bronchospasms, making them appropriate option and also a safe type of snack, especially for this child with asthma. Now, what about letter A, a glass of cold milk? We know that milk generally is a healthy choice for a toddler, but the word cold is not recommended for a child with asthma. Yeah, this can trigger the bronchospasms in some individuals with asthma. Therefore, a cold beverage like milk could aggravate the child's symptoms, and so it should be avoided at all costs. What about letter C, grapes? This can pose a serious choking hazard for young children. We're talking about 2-year-old, especially for toddlers who may not be able to chew them properly yet. And also the shape and the skin of grapes make them particularly dangerous for children under 4 years of age. And in this case, even though grapes are nutritious, they are not safe for a 2-year-old toddler due to the choking hazard. What about letter E? Oatmeal cookies. That kind of seem like a convenient snack, right? They are typically high in sugar and fat, which makes them a less healthy choice compared to fruits or vegetables. And since they are not as nutritious as other options like sliced apples or chopped vegetables, they don't meet the criteria for a healthy snack for a toddler with asthma. Next, we have ice cream. It's cold and could precipitate bronchospasms in a child with asthma. And in addition to that, cookies, ice cream is also high in fat and sugar, making it an unhealthy snack. And it's better to opt for snacks that don't pose a risk of triggering asthma symptoms and are nutritious. Let's have number 39. A client is prescribed valsartan, Diovan, an angiotensin II receptor blocker. Which potential side effects should the nurse assess for? Select all that apply. A, difficulty with bowel movements. B, irregular heart rhythm. C, a drop in blood pressure when changing positions. D, low potassium levels. And E, blurred or altered vision. Now, this question asks the potential side effects of valsartan or Diovan, which is an angiotensin II receptor blocker, or simply ARB. And the goal is to identify which side effects the nurse should assess for in a client taking the medication. Now, the question here is asking you to select all that apply, which means there's going to be multiple correct side effects here. Okay. So you have to pay attention to the common side effects associated with ARBs. So it might be dizziness, could be hypotension, it could be cardiac issues. And so we have the following correct answers here. What are these options? So these are your options B and C. Why letter B? Yes, this is one of the side effects of the ARBs. That's going to be irregular heart rhythm. Yeah, particularly second-degree heart block. And these are serious side effects that require the nurse to assess for any irregular heart rhythms. And we have letter C, a drop in blood pressure when changing positions. So similar with other ARBs, the valsartan can also lower the blood pressure. It blocks the vasoconstrictor and aldosterone producing effects of angiotensin II. And this can lead to orthostatic hypotension, where the client experiences a drop in blood pressure when changing positions, especially from supine to a standing position. And so it's important for the nurse to monitor for dizziness or lightheadedness that can result from this effect. So this answer is correct. Now, why letter A is incorrect? Constipation is not a common side effect of valsartan. Okay, the primary gastrointestinal side effects for ARBs are typically mild and may include symptoms like nausea, diarrhea, but constipation is not typically associated with valsartan. So eliminate this one. Letter D, low potassium levels. Well, valsartan actually tends to increase potassium levels in the blood due to the suppression of aldosterone. And I want you to recall that aldosterone in the normal physiology normally helps the body excrete potassium. So when the action of aldosterone is blocked with the use of this medication, there can be a risk of hyperkalemia, because the aldosterone, which is the main regulator of potassium, is no longer produced in normal amounts. So this can lead to hyperkalemia. So this makes this answer incorrect. Not low potassium levels, but rather the ARBs can lead to hyperkalemia. Letter E, blurred or altered vision. Well, valsartan does not typically cause changes in the visual acuity. Blurring of the vision is not a known side effect of ARBs like valsartan, and the vision changes are generally not linked to this kind of classification. So when you're answering questions about medications like valsartan, it's essential that you recall the typical side effects associated with this class of medication. Okay, so I want you to recall for ARBs, or angiotensin II receptor blockers, the common side effects are hypotension, dizziness, and potential heart rhythm changes. All right. 40. A client is in the ICU suspected of having adult respiratory distress syndrome, or ARDS, and is receiving 10 liters per minute of O2 via nasal cannula. Which ABG result suggests the absence of ARDS? Well, the question is asking you to interpret ABG results in a client suspected of having adult respiratory distress syndrome, and to identify which result suggests the absence of ARDS. And again, I want you to remember ARDS is characterized by severe hypoxemia, and understanding how ABG values reflect the severity of the condition is very critical for identifying whether ARDS is present or not. Now, I want you to look for the clues in the questions like the 10 liters per minute of O2. This indicates that the client is already receiving a significant amount of oxygen. Now, In ARDS, oxygenation failure occurs despite high levels of O2 support. And so partial pressure of oxygen levels will typically be low. And the critical word to focus on here is absence of ARDS. That's what's being asked in the question. So it means we are looking for ABG results that show adequate oxygenation in normal respiratory status. Now we have to pay close attention to the PaO2, or the partial pressure of the oxygen, which is the most significant indicator for ARDS. Now, what's the answer here? The answer is letter C. And why is that? Well, take a look into the PaO2 of 82. Okay, that is within a normal range. The range usually sits around 80 to 100 mmHg, and this alone suggests that there is adequate oxygenation. Now take a look into the pH in option C. It is 7.38. It is within the normal range of 7.35 to 7.45. And the partial pressure of the carbon dioxide of 45, even though it's normal, right? 35 to 45 is the range. And it suggests no signs of respiratory distress or failure. Now, the absence of significant hypoxemia, the PaO2 is above 60, indicates no ARDS. And so this set of ABG values suggests that there is no ARDS. Now let's go into letter A. Well, the PaO2 in letter A of 74, it is low and could indicate that early stages of ARDS, particularly when considering the patient's oxygen therapy. And also look into the pH in option A. Slightly acidic, even though it's in the normal range, but it's in the lower limit, okay, towards the end, cutoff of the pH, which could also be an indication of impaired gas exchange. Now, the low PaO2 level and slightly acidic pH indicate that the patient is not oxygenating well, making this is a more consistent range of values for ARDS. Now, what about letter B? Okay, what's in letter B? The PaO2 in letter B is 60 mmHg. This is low. It indicates hypoxemia. And the pH of 7.45 is on the alkaline side, normal, but on the cutoff, which may be a compensatory mechanism in response to low oxygen levels. Now, the elevated PaCO2 suggests that the patient is retaining carbon dioxide, which is common in ARDS, when the lungs cannot clear carbon dioxide properly. And so this set of values is indicative of ARDS, as it shows hypoxemia despite oxygen therapy. And lastly, we have letter D. Look into the PaO2 of 50. This is a severe case of ARDS. The PaO2 of 50 is critically low. It suggests severe hypoxemia, which is characteristic of ARDS. Now, also take a look into the pH, 7.32. It's acidic. It indicates that the patient is retaining acid. So there's possibly respiratory acidosis. And the PaCO2 of 55 is elevated. It further confirms respiratory failure despite the bicarbonate level of 28 being on the higher end. The severe hypoxemia indicates ARDS, not the absence of it. So let's have number 41. A client with type 2 diabetes inquires, why is it concerning if my blood sugar is elevated? I feel fine. What is the most suitable response from the nurse? A, high blood glucose can lead to metabolic acidosis. B, over time, elevated glucose can damage your kidneys and eyes. C, high glucose can cause issues with both small and large blood vessels. And D, as long as you feel fine, there's no need to worry. Now, the question is asking about the nurse's response to a client with type 2 diabetes who doesn't feel unwell despite having elevated blood glucose. And the client is looking for an explanation of why high blood sugar is a concern even when they don't feel immediate symptoms. Now, I want you to pay attention here because this is a common situation in diabetes management, as many complications from high blood sugar can develop over time without noticeable symptoms. Now, for you to answer this question correctly, I want you to acknowledge that the key here is recognizing that long-term complications from elevated blood glucose are the focus, especially because the client feels fine. Now, the immediate symptoms aren't the issue here. Chronic effects on the organs are. And so when you see the answer choices that focus on long-term damage to organs like kidneys or eyes, that's a strong indication of the correct response. Now, I want you to watch out for specific medically accurate explanations. You want to choose the option that most clearly explains the long-term risk of elevated blood glucose without making the explanation too complex. And so the correct answer here is letter B. This is the most accurate response because it focuses on long-term effects, which is exactly what the client is needing to understand. And also take note that chronic high blood sugar levels can damage both the small blood vessels. It can lead to retinopathy in the eyes and nephropathy in the kidneys. And this is a very common and important reason why it's crucial to maintain proper blood sugar control in diabetes, even if the client doesn't feel symptoms right away. And so this explanation is also easy to understand for a lay person. Now, letter A is an incorrect option here. We know that metabolic acidosis can occur in diabetic ketoacidosis in type 1 diabetes, but it is not typically seen in type 2 diabetes. Now, type 2 diabetes more commonly leads to the hyperosmolar hyperglycemic hyperosmolar hyperglycemic non-ketotic syndrome, or what we refer to as the HH&S, not metabolic acidosis. So this makes A incorrect, as it's not a common concern for type 2 diabetes, and the client is specifically asking about why elevated glucose is concerning in their case. Now, letter C. Why is this incorrect? Well, this option introduces a more technical explanation about microvascular and macrovascular damage. We know that this is accurate in terms of diabetic complication, but it's a bit too detailed for the client's level of understanding and doesn't really address the most common concerns like kidney and eye damage, which are more straightforward and commonly understood by the general population. And so the client may not fully grasp the connection between vascular damage and long-term complications. So this makes this option less effective for the question. Now, letter D. This is also incorrect because it dismisses the importance of long-term glucose control. And again, diabetes is a silent disease, meaning that complications often develop without immediate symptoms. Just because the client feels fine doesn't mean their glucose levels aren't causing harm over time. And so this response in option D is misleading and dangerous, as it could lead the client to believe they don't need to be concerned about their elevated blood sugar unless they experience symptoms. And so I want you to strategize in answering this question. And the most critical piece of information here is that high blood glucose can cause long-term damage to the organs, particularly the eyes and the kidneys, which are common areas affected by type 2 diabetes. And when you are answering this question, you got to look for the options that connects elevated glucose levels to chronic damage to organs and making it easy for the client to understand the need for controlling the blood sugar levels. 42. A client with an acute flare-up of Crohn's disease is being assessed. Which finding requires the nurse's immediate attention? A, the client's serum amylase is 100 units per deciliter. B, the client's white blood cell count is 10 times 10 raised to the power of 3 per cubic millimeter. And C, the client's blood glucose is 148 milligrams per deciliter. And D, the client's serum potassium level is 3.2 milliequivalents per liter. So this question is assessing your ability to identify a priority finding in a patient with an acute flare-up of Crohn's disease. And it often involves diarrhea, abdominal pain, inflammation of the gastrointestinal tract. And this is also asking you to pick the most urgent issue from a set of lab results. And the key here is to recognize which abnormal result would pose the greatest immediate risk to the client. So I want you to look for the critical findings that suggest imminent risk to the client's safety, such as the imbalances in their electrolyte or possibly changes that could affect the vital organs such as the heart. And in this case, the low potassium is a red flag, and that is why that is the answer to the question. Yes, because potassium level of 3.2 is low, and it can lead to cardiac arrhythmias and muscle weakness, both of which can quickly become life-threatening. And the diarrhea is a common symptom of Crohn's disease. It's easy to see why hypokalemia would be a concern, and it should be addressed immediately to prevent further complications. Now, letter A is an incorrect option here. This is within the normal limits for amylase, okay? It typically ranges around 50 to about 180 units per deciliter. We know that amylase is that enzyme related to pancreatic function, and this level does not indicate any immediate problems related to the acute flare of Crohn's disease. Now, letter B is also incorrect. Why? Well, this is within the normal limits. Typically, the white blood cell count ranges from 4,500 to 11,000 per cubic millimeter, and while it might indicate some inflammation, because we are in the upper normal limit, could indicate some inflammation or maybe infection, it's not alarming in the context of a flare-up in Crohn's disease, where the white blood cell has that increase. Now, it would not require immediate attention unless if we're significantly elevated, which this is not. Now, what about letter C? Letter C with a glucose of 148 milligrams per DL. This is slightly elevated, but it's not typically a cause for immediate concern unless the value is much higher, such as in a case of diabetic ketoacidosis, or if the client has underlying diabetes. And it's not specifying that this is fasting blood glucose. No, it's not. And so I would not be too worried about that value. And so for a patient with Crohn's disease, this is likely not a critical issue that requires urgent intervention compared to the hypokalemia in option D. So when you are presented with the lab values in a clinical scenario, you need to prioritize the findings that could lead to acute, life-threatening complications. Anything that could lead to a disturbance in the heart function, arrhythmias, which could further lead to hemodynamic instability. So that would be your focus, right? And always focus on findings that suggest the potential for organ failure or immediate instability. Let's have number 43. A client with a long history of alcohol dependence has completed a 28-day rehabilitation program for alcohol treatment. Which type of referral should the nurse prioritize in the client's discharge plan to support continued recovery? A, community-based self-help group. B, halfway house. C, family therapist. D, psychoanalytic therapy group. Now, this question is asking you to identify the most appropriate referral for a client who has recently completed a rehabilitation program for alcohol dependence. And the goal is to provide ongoing support to maintain sobriety and also to prevent relapse. Now, the options give you different types of support services, so you need to think about which one will be most effective to help the client transition into a long-term recovery after rehab. And so when you're answering this type of question, it's important to look for clues about long-term recovery and continuity of care. And in recovery from alcohol dependence, peer support and structured follow-up are often the most helpful tools in preventing relapse. And so you need to focus on referrals that encourage long-term support and accountabilities, let's say self-help groups, rather than options that might be better suited for acute or short-term needs. And that is why the answer is letter A. This is the most suitable option. Okay, so this is actually referred to as the Alcoholics Anonymous. These groups offer peer support, which is one of the most critical factors in maintaining long-term sobriety. And also the self-help groups provide a supportive environment for individuals who are recovering from alcohol dependence. And they also offer ongoing non-judgmental support. And this can help the client to continue to work on their recovery, learn from others with similar experiences, and also to avoid isolation, which is a key factor in preventing relapse. Plus, these groups are widely accessible and a cost-effective resource. What about letter B, halfway house? This is incorrect. We know that a halfway house, or they're called as sober living facility, which can be helpful for people who need more structure and support after rehabilitation. But the scenario doesn't suggest that the client lacks a stable home environment or has a history of frequent relapse. And take note that halfway houses are typically reserved for people who need a transitional living environment because they are either homeless, or they either lack social support, or are in need of a controlled space to prevent further relapse. And since this question doesn't mention these factors, a community-based self-help group is a more appropriate referral. Letter C, family therapist. We know that family therapy is also crucial for addressing family dynamics that may have contributed to alcohol dependence, such as codependency. But it is not typically the first priority in the discharge plan. The most immediate need for someone recovering from alcohol dependence is support from peers who have been through similar experiences. And while family therapy could be useful for long-term recovery, the priority should be ongoing sobriety support through a group or the Alcoholics Anonymous, where the individual can relate to others in a similar situation. Letter D, psychoanalytic therapy group. Well, they're going to delve into unconscious conflicts and past experiences, and is more time-consuming and long-term. And this approach is generally not as effective in the immediate phase of the recovery for alcohol dependence. Instead, the evidence-based behavioral therapies like cognitive behavioral therapy combined with peer support groups have been shown to be more effective in preventing relapse. So again, the client needs practical, structured support, and psychoanalytic therapy doesn't offer the immediate tools needed to maintain sobriety. All right. So main key takeaway here is that when the goal is long-term recovery from alcohol dependence, the most effective and accessible support comes from peer-based self-help groups like the Alcoholics Anonymous. Let's have number 44. Following delivery, a client experiences heavy bleeding. The healthcare provider has ordered fundal massage and started an IV infusion of oxytocin, 10 units in 100 mL per hour. The nurse notes that the client's blood pressure is 137/92 mmHg. The uterus feels buggy and is palpable 3 centimeters above the uterus, feels 3 centimeters above the umbilicus, and is displaced to the right. And the perineal pad is saturated with bright red lochia. What should the nurse do next? A, Evaluate the client for a possible distended bladder. B, continue the fundal massage. C, increase the rate of the oxytocin infusion. And D, keep monitoring the blood pressure. This question is about postpartum hemorrhage and what the nurse should do when the client is experiencing heavy bleeding. And so the key point is to focus on identifying and correcting the underlying cause of the bleeding. And the scenario presents a buggy uterus, displaced uterus, and bright red lochia, all of which point to the potential for a full bladder being the culprit. Now, the question is asking what the nurse should do next, which means you need to consider the priority action to take at this moment. Now, when dealing with this clinical question, you need to identify the most likely cause of the issue. All right, so you got to look for the clues again: buggy, displaced, bright red lochia. So what is the answer here? That is going to be letter A. The buggy and displaced uterus, there's 3 centimeters above the umbilicus and displaced to the right, are key signs that the uterus might not be able to contract properly due to a full urinary bladder. Now, I want you to recall that a distended bladder can cause uterine displacement, and it's going to make it difficult for the uterus to contract. It can lead to heavy bleeding. So letter A is the correct answer, because the nurse should first assess for this likely cause by having the client void and then reassess the fundus. Now, if the uterus remains buggy after the bladder is emptied, you need to do some more further interventions, let's say fundal massage. Now, why is letter B incorrect? Continue the fundal massage. We know that this is an appropriate action for a buggy uterus, but this should be done after addressing the possible cause, in this case, a distended bladder. Because if the bladder is not emptied, the uterus will remain displaced and continue to be buggy. Again, so to continue the fundal massage without addressing the bladder issue, this is going to be premature. It's going to be useless. You need to address first, or to assess the bladder first, to determine if that's causing the issue. Letter C. Why is this incorrect? It's because oxytocin is used to stimulate uterine contractions, but it's not the first step in maintaining a buggy uterus caused by a full bladder. And correcting the underlying cause, such as the bladder distension, is the priority. All right, letter D. Another incorrect option here. We know that monitoring the blood pressure is important. It's not the priority action in this situation. The client is bleeding, and this is related to the buggy uterus caused by a distended bladder. So immediate intervention should focus on correcting the uterine condition. Okay. Now, the main key takeaway here for this test question, and answering this test question rather, is to prioritize that action to correct the uterine displacement, which is most likely due to a distended bladder. Let's have number 45. While accompanying a 3-year-old to the playroom, the child seems hesitant to engage with toys or activities. Which toys should the nurse suggest based on the child's age? Select all that apply. A, toy phone. B, plastic tea set. C, clay and molds. D, crayons and paper. And E, simple video game. So this question is about selecting the appropriate toys for a 3-year-old child based on their developmental stage. And take note that this stage, children are typically in the toddler phase, right, or stage. So about 2 to 3 years old, and they are progressing through certain types of play, such as imaginative and creative play. So take note of that. So the question requires you to identify the toys that would best support these developmental milestones. So I want you to look for the developmental clues in both the question and the answer options. Words hesitant, okay, right here, and engage with toys. And the child, and the age of the child here, which is 3 years old, are signals that you need to select age appropriate and developmentally appropriate toys. And so for a 3-year-old child, you need to focus on imaginative play, fine motor skills, and creativity. So these are typical of toddlers. And what you need to do here is to eliminate those options that involve activities that are too complex for a child to this age, and anything that requires fine motor control or cognitive abilities beyond their developmental level. And so the correct answers in this question are letters A, B, and C. And why letter A? Because this can encourage imaginative play, and toddlers at this stage engage in imitation, like talking on the phone, which allows them to practice social skills and mimic real-life activities they see adults do. And this type of play is typical of toddlers and helps them develop a cognitive and also their social skills. The plastic tea set in letter B also supports pretend play, and this will allow them to engage in a symbolic play, and they enjoy creating their own scenarios and stories, like pretending to have a tea party. And it also helps with creativity, social interaction, and role playing, all of which are very critical components of a toddler's development. Letter C, another correct option here, because clay and molds are excellent for fostering creativity. It can develop fine motor skills, and they also enjoy manipulating Play-Doh or clay to create shapes, which helps with their hand-eye coordination, also the dexterity and spatial awareness. And in addition, this kind of play is open-ended. It will allow the toddler to use their imagination while building different shapes. Now, what about letter D? Crayons and paper. We know might be appropriate for a 3-year-old child, but again, the child is still developing fine motor skills, and they may not have the control to use crayons effectively without making a mess or, let's say, potentially hurting themselves. So it's a bit early for many toddlers to have the fine motor coordination needed for drawing or coloring neatly, and it's better suited for slightly older children who have better hand control. And letter E, simple video game, are not appropriate for the 3-year-old as well, because around this age, the child does not have a cognitive ability yet to understand video games, nor they have the fine motor coordination needed to interact with controllers or, let's say, screens. And the video games are more suitable for older children, as they are going to require a higher level of focus, also with a problem solving, hand-eye coordination that toddlers do not yet possess. And so the main key takeaways here is to consider age-appropriate play for a 3-year-old. That includes toys that promote imaginative, symbolic, and creative play. And you need to eliminate those options that involve higher cognitive or motor skills not suited for toddlers, such as playing video games and the use of crayons. Number 46, a nurse suspects an intestinal obstruction in a 3-month-old infant presenting with a distended abdomen and bile-stained vomiting. Which other symptoms support this suspicion? Select all that apply. A, sudden severe abdominal pain. B, difficulty breathing or grunting respirations. C, weak pulse. D, decreased muscle tone. E, high-pitched abnormal cry. So the question is asking you about identification of symptoms of intestinal obstruction in a 3-month-old infant, which is a critical condition that requires quick diagnosis and intervention. So the key clues in the question are distended abdomen and bile-stained vomiting, which are classic signs of an obstruction. And so your task is to select additional symptoms that would align with this condition in this infant. So what I'm going to need you to do here is to focus on the symptoms that directly relate to an abnormal obstruction. okay, especially those that can arise from a pressure on the abdominal organs and the digestive tract, and also to look for physical signs of distress, let's say pain, respiratory issues, or digestive problems. So these are more likely to be seen in an infant with a significant obstruction. I also want you to eliminate those symptoms that seem unrelated to the abdominal issue or don't logically connect to the obstruction, such as neurological signs or cardiovascular issues. And so the correct answers here are letters A and B. Now, why letter A? This is a key symptom of an intestinal obstruction in infants. The pain is usually caused by the intestines attempting to push food and gas past a blockage. This can lead to paroxysmal pain, which is intermittent, severe pain due to the peristalsis. And in infants, this may appear as crying and pulling the legs towards the abdomen, which is characteristic of colic or distress from pain. Letter B, another correct option here. As the abdominal distension increases, it can put pressure on the diaphragm, which can lead to respiratory distress in infants. And the grunting respirations are a compensatory mechanism to help keep the airways open, which is a clear sign that the infant is struggling to breathe. Now, this symptom is often associated with abdominal problems, including an obstruction that affects both respiratory and gastrointestinal systems. Now, what about letter C, weak pulse? This is not typically associated with an intestinal obstruction. We know that with an obstruction, this can lead to shock, right? In severe cases, it's more likely due to fluid loss or possibly dehydration. Could be from vomiting or inability to pass the stool than the obstruction itself directly affecting the pulse. And so this option is more indicative of fluid imbalance or shock rather than the obstruction directly. Now, what about letter D? Decreased muscle tone, or this is the hypotonia. So this is unrelated to an intestinal obstruction. And while it can be a symptom of neurological conditions, it is not a hallmark sign of gastrointestinal issues like an obstruction. This would point toward neurologic disorders rather than a problem related to a problem in the digestive tract. Now, what about letter E? High-pitched abnormal cry. Well, in an infant, it's often linked to neurological problems such as intracranial pressure increases or neurological distress, but not specifically to intestinal obstruction. Although an infant with a severe obstruction might cry from pain, but a high-pitched cry is not a classic sign of this condition. It's more often seen in meningitis, could be intracranial hemorrhage, so it doesn't really match the clinical picture of a gastrointestinal obstruction. All right, let's have number 47. A client develops a DVT and pulmonary embolism after surgery and is receiving heparin through a continuous IV infusion at 1,200 units per hour. A few hours later, the provider prescribes vancomycin 500 milligrams IV every 12 hours, and the client has only one IV site in the left forearm. What action should the nurse take? A. Insert an additional IV line for the vancomycin while maintaining the heparin infusion. B. Temporarily stop the heparin, flush the line, and administer the vancomycin. C. Use a secondary piggyback setup to infuse the vancomycin into the same IV line as the heparin. And D. Withhold the vancomycin and inform the provider about its incompatibility with heparin. Now, this question involves managing two different medications. We have heparin and vancomycin for a patient who has developed DVT and PE post-op. And so the key issue here is that these two meds are incompatible in the same IV line. So the nurse needs to determine how to administer both safely. And so you need to look for the key terms in the question and answers. Continuous IV infusion. Take note, continuous IV infusion. This is the heparin. And the IV site, there's only one single IV site in the left forearm. So this will help you guide in understanding the challenge of administering two incompatible medications through a single IV. And the critical concept in this question is the incompatibility of the two drugs. So always check for drug compatibility when multiple medications are ordered to be given through the same line. Now, I want you to eliminate answers or options that involve administering the drugs in a way that could potentially harm the client, such as mixing incompatible drugs in the same IV line. And so the answer is letter A. This is the best choice because it ensures the heparin infusion continues without interruption and the vancomycin is given via a separate line to avoid the issue of drug incompatibility. Now, I want to emphasize here that studies have shown that even brief interruptions in the anticoagulation therapy can increase the risk of thrombus recurrence, meaning it can possibly cause an enlargement of the pre-existing clot that has lodged probably in the leg, or probably the clot that has lodged in the arterial circulation, in the pulmonary artery, I should say. And a continuous infusion of heparin should maintain a therapeutic APTT level, so to ensure much more effective anticoagulation. So when medications are incompatible, they should not be infused through the same IV line to prevent potential adverse reactions or precipitate formation. Now, why is letter B incorrect? Temporarily stop the heparin, flush the line, and administer the vancomycin. This is incorrect because stopping the heparin would interrupt the treatment for the DVT and PE, which is undesirable. And the word flush the line, it does not guarantee that remnants of heparin would be completely removed, and remnants can still cause incompatibility when the vancomycin is introduced, and this approach may not adequately address the safety concerns related to mixing the two medications. Letter C, another incorrect option, because heparin and vancomycin are widely incompatible, cannot be given in the same line, even with a piggyback setup. And a piggyback setup is usually used for medications that are compatible with the primary infusion. And since vancomycin and heparin don't mix well, they should not be administered through the same line. What about letter D? This is also incorrect because withholding the vancomycin is not appropriate response unless the provider explicitly decides to hold the medication, and the nurse is responsible for ensuring safe administration, and informing the provider does not resolve the immediate issue of incompatibility. The nurse should take action, such as starting a second IV line to administer both drugs safely. Let's have number 48. A client with rheumatoid arthritis is prescribed aspirin. What signs of aspirin toxicity should the nurse instruct the client to report? Select all that apply. A, increased joint discomfort. B, persistent ringing in the ears. C, presence of blood in the stool. D, nausea or upset stomach. And E, increased urine production. Now, the question focuses on aspirin toxicity in a client with rheumatoid arthritis. And aspirin, while effective in managing inflammation and pain, can lead to toxic effects, and the nurse needs to educate the client on the signs of toxicity. So the keywords here are signs of toxicity. And so when you see this, it signals that you're looking for symptoms associated with overdose or adverse reactions to aspirin. Now, the answers here are options letter B and C. Why letter B? Because this is a classic symptom of aspirin toxicity known as tinnitus. And recall that aspirin is a salicylate, and one of the well-known adverse effects is ototoxicity. This is the ringing in the ears happening because the aspirin itself can affect the eighth cranial nerve, the vestibulocochlear nerve, right? This is the nerve that is responsible for the hearing. Now, this symptom is important to report because it can signal serious toxicity that may require adjusting the dosage or possibly discontinuation of the medication. Now, letter C is also correct. The presence of blood in the stool is another key sign of aspirin toxicity. We know that aspirin has a well-known anticoagulant effect, which can lead to GI bleeding. And the blood in the stool may appear as a black tarry stools or melena, or maybe bright red blood. It depends on the location of the bleeding. And this should be reported immediately because this can indicate serious internal bleeding, which can be life-threatening if not addressed promptly. Letter A is incorrect because increased joint discomfort is not a sign of aspirin toxicity. In fact, aspirin is prescribed for pain relief in conditions such as RA. So this would be expected as part of the disease process, not an adverse effect. Now, if the pain worsened, it could be due to the inflammation or exacerbation of the condition, but not related to toxicity. Letter D is also incorrect because nausea or upset stomach is a common side effect of aspirin, but not necessarily indicative of toxicity. It can occur at therapeutic doses due to the irritation aspirin causes in the GI tract. Now, this is often the symptom of bleeding here is often managed with the food, giving the medication with food, or maybe instead of giving the regular aspirin, this can be given with the use of an enteric-coated form of aspirin. But it doesn't really point directly to toxicity unless other symptoms are present. Now, what about letter E, increased urine production? This is incorrect because increased urine production is not typically associated with aspirin toxicity. And aspirin does not usually cause diuresis. This symptom could be related to other conditions or medications, but not aspirin toxicity. Now, 49, an older adult with arthritis is prescribed ibuprofen and hydroxychloroquine, Plaquenil. What side effects should the nurse instruct the client to report? Select all that apply. A, difficulty swallowing. B, blurry vision. C, increased tendency to bleed. D, trouble urinating. E, unusual feelings of irritability. Now, this question is about side effects related to the two medications, ibuprofen and the Plaquenil, which are commonly used in the management of arthritis. Now, pay attention to the hydroxychloroquine or the Plaquenil. This is used in this particular scenario. This is used as a disease-modifying anti-rheumatic drug, or known as DMARD, and the therapeutic use is to reduce the inflammation and also to slow down the disease progression. Now, this is also a medication that is known to be used for the treatment of malaria, and this is also an immunomodulator. This is going to regulate immune system activity, particularly in immune or autoimmune diseases. And so the nurse needs to educate the client on serious side effects that require immediate attention. So the correct answers here are letters B and C. Why letter B? Blurry vision. This is a known side effect associated with Plaquenil. Why? Because the hydroxychloroquine has a thing for melanin, which is found in the retinal pigment, which is the epithelium, which is also a layer of cells that keeps the retina healthy. Now, since the drug sticks to melanin, it will accumulate over time, and the longer you take it, the higher the risk of damage. Now, the retina has a ton of mitochondria as well, which is the energy powerhouses of the cells, and the hydroxychloroquine interferes with how they work. So this can lead to oxidative stress, which can cause cell death and also thinning of the retina over time. Now, the risk of blurry vision is going to increase especially with high doses, or let's say when there is prolonged use. So it's crucial that the client report any changes in the vision. Alrighty. And so the answer in letter C, increased tendency to bleed. This is a side effect that's associated with ibuprofen, which is an NSAID. We know that this can increase the risk of bleeding by inhibiting platelet function and can also lead to thrombocytopenia or GI bleeding, both of which can be life-threatening. Now, the options A, D, and E are all incorrect. Why is A incorrect? This is not a common or expected side effect of either ibuprofen or hydroxychloroquine. Letter D, trouble urinating. This is also incorrect because urinary retention is not related to ibuprofen or hydroxychloroquine. We know that kidney function may be impacted by NSAIDs, especially in older adults or those with pre-existing kidney issues, but trouble urinating is not a typical or immediate side effect of these medications. Now, letter E, we have unusual feelings of irritability. This is also incorrect because irritability is a mild side effect that is not considered serious or life-threatening. We know that both medications can have mood effects, irritability and restlessness. So this is not an urgent symptom that needs immediate report. All right, let's have number 50. A young client with a recent spinal cord injury is having difficulty coping with paralysis. One day, they experience intense leg spasms and say, "My strength is coming back. I know I'll be able to walk again." The nurse's response should be based on which understanding? A, the resolution of spinal shock has led to increased reflex activity. B, reduction in swelling may be allowing some motor function to return. C, nerve regeneration is occurring and movement is improving. D, the client may have developed a blood clot leading to pain. Now, let's break down the question here. It's centered on this young client with a recent spinal cord injury who is experiencing intense leg spasms and expressing the belief that they will be able to walk again. Now, the nurse needs to provide a response that is based on the pathophysiology of spinal cord injury and spinal shock recovery. So the keywords that you need to pay attention to would be spinal cord injury, difficulty coping with paralysis, and intense leg spasms. And the client's statement, "I'll be able to walk again." So these points to spinal shock, recovery, and the return of reflexes. And so you want to focus on a response that addresses hyperactive reflexes or spasticity during recovery. Now, I want you to focus on the correct physiological response to spinal shock recovery. And the correct answer should align with involuntary muscle spasms, indicating hyperreflexia during recovery. And so the correct answer here is letter A. It's because this response addresses what happens after spinal shock resolves. And in spinal shock, there is a loss of reflex activity leading to flaccid paralysis. And as the shock resolves, the spinal cord reflexes may return. It can cause spasticity or involuntary muscle spasms. And these spasms are a result of hyperactive reflexes, not voluntary movement. And so this aligns with the client's statement about feeling strength returning even though the paralysis persists. And so the nurse here should clarify that the spasms are not a sign of motor function recovery, but rather a normal part of recovery from spinal shock. And so the rest of the options here, such as letter B, reduction in swelling, may be allowing some motor function to return. What's the reason for that? Well, it's because the reason here is incorrect because swelling reduction does not lead to motor function return in the case of a severed spinal cord. Now, if the spinal cord is severed, the paralysis remains regardless of the swelling. And although the swelling may affect the spinal cord's function, it does not lead to the recovery of motor function in cases of complete spinal cord injury. Letter C is also incorrect because the nerve regeneration does not occur in spinal cord at the level necessary to restore the motor function after a severe injury. And while there is ongoing research into spinal cord regeneration, but currently severed spinal cord nerves do not regenerate. And so meaning the motor function will not return, even though reflex activity may increase as the body tries to recover from a spinal shock. What about letter D? This is also incorrect because a blood clot, such as the deep vein thrombosis, is a common complication in patients with spinal cord injuries due to immobility, but it would not explain the client's belief that they will walk again. And the leg spasms are related to hyperreflexia after the resolution of spinal shock, not a clot. Now, the main key takeaways for you to answer this question is to recall that the return of the reflex activity after spinal shock results in spasticity and leg spasms, which are involuntary and not a sign of motor function recovery. So, this is a very critical point in understanding or explaining into your client, especially for those who are recovering, especially spinal shock recovery. So, my test taking tip for you is to eliminate those options that suggest motor function recovery or nerve regeneration unless 51. A client at 39 weeks gestation with spontaneous rupture of membranes is admitted to the birthing unit. Evaluation in the emergency department shows a cervix dilated to 4 centimeters with 75% effacement and a fetal heart rate of 136 beats per minute. Upon admission, what is the nurse's first priority? A. Introduce the couple to the nursing staff to help them feel comfortable. B. Position the client in bed and attach an external fetal monitor. C. Have the client remove her gown while obtaining her history from her partner. And D. Ask the couple to wait in the examination room while the healthcare provider is notified. Now, the scenario is about a client at 39 weeks gestation with spontaneous rupture of membranes who is admitted to the birthing unit. And the nurse needs to prioritize actions based on the client's status, which includes being in early labor with a dilated cervix at 4 centimeters, 75% effacement, and a stable fetal heart rate at 136 beats per minute. Now, the priority at this moment is to address immediate nursing needs while the client is in labor. Now, the answer here is letter A. And why is that? Because the client is in early labor, first stage with a stable condition, and the priority in the early stages is providing emotional support and reducing anxiety for both the client and her partner. And we know that building a trusting relationship is critical at this stage because it helps the couple feel more comfortable and also engage during the labor process. And this will also allow them to feel more supported as the labor progresses. Now, why B is incorrect this time? It's because we know that fetal monitoring is necessary throughout the labor, but the priority right now is not the technical aspects of positioning and monitoring. And the client's fetal heart rate is stable, 136 beats per minute. So there's no immediate need for the monitoring equipment at this moment. And we know that emotional support takes precedence over starting invasive procedures or equipment setup. Letter C is also incorrect because the history should be obtained from the client, not the partner, if she is capable of providing it. And taking a full history is important, but it is not the priority immediately upon admission if the client's condition is stable. And also, having the client remove her gown is a secondary consideration and should be done when more pressing concerns are addressed. Now, letter D this is also incorrect because the healthcare provider may have already been notified, especially considering that the client is already admitted to the birthing unit. And waiting in the exam room is unnecessary at this point, and it is more important to provide the couple with emotional support and care at this time of admission, which will help reduce the anxiety. Again, the priority in this situation is emotional support, also with the establishment of a trusting relationship with the client and her partner. And again, this is a stable client right now. Now let's have number 52. A nurse is conducting an assessment on a patient diagnosed with primary insomnia. Which elements from the patient's history could potentially be contributing factors to this sleep disorder? Select all that apply. A, constant environmental noise. B, ongoing stress. C, high caffeine intake. D, intense anxiety. E, chronic pain. F, long-term depression. Now, the question is asking about primary insomnia. That's your clue right there, which is a type of a sleep disorder where the cause is not directly related to any underlying medical condition or substance abuse. Instead, the cause can often be attributed to environmental, emotional, or lifestyle factors. And this question wants you to identify factors from the patient's history that might contribute to primary insomnia. Again, the keywords here are primary insomnia, which means the sleep disturbance is not caused by a secondary issue like pain, anxiety, or depression as underlying conditions. So you need to focus on factors that directly disrupt sleep but are not caused by another medical condition. So you're going to look for lifestyle or environmental factors. So words like constant, environmental noise, ongoing stress, and high caffeine intake are likely contributors to insomnia. And that is why our correct answers are the following. We have letters A, B, and C. A, because environmental noise can directly affect sleep by causing physical or emotional discomfort, which will disrupt the ability to fall or stay asleep. And of course, in cases of primary insomnia, again, external disturbances like noise are significant contributors. Now, what about letter B here? Ongoing stress. This is also correct. This can lead to insomnia by making it difficult for the individual to relax or unwind enough to sleep. So this could be stress, whether it's emotional or physical. And this also fits into the primary insomnia, as stress is not always due to a specific medical condition, but is a common environmental factor affecting sleep. Letter C is also correct because caffeine is a stimulant that can interfere with sleep by disrupting the sleep-wake cycle, especially if consumed too close to bedtime. It's a lifestyle factor not related to a medical condition, making it relevant to primary insomnia. Now, what about letter D? Intense anxiety. This is incorrect because anxiety is often tied to a psychiatric disorder, which usually would lead to secondary insomnia, not primary. And letter E, chronic pain. This is also incorrect because chronic pain is usually related to a medical issue or a neurological issue like arthritis, maybe an injury or other conditions which causes secondary insomnia. And pain is typically the result of an underlying health problem that leads to disturbed sleep. Now we have letter F, which is also incorrect because depression is a psychiatric disorder. We're talking about long-term depression, and it also affects on sleep, right? Again, depression often affects sleep patterns. It's considered a secondary cause because it is a psychiatric condition. Now, I want you to identify the underlying causes. And when you're assessing insomnia, remember that primary insomnia is not due to another underlying medical or psychiatric condition, whereas secondary insomnia, this is related to conditions like chronic pain, depression, anxiety, that could be causing sleep issues, points toward this type of insomnia. And so I want you to look for the environmental or lifestyle factors and also to rule out secondary causes. All right, let's have 53. A 2-week-old infant is admitted with a suspected ventricular septal defect, and the parents report feeding difficulties since discharge. What factors should the nurse take into account before responding? A. Feeding issues are typical in newborns. B. It is common for neonates to have mucus retention, which can affect feeding for several weeks. C. Insufficient sucking is not concerning unless cyanosis is present. D. Difficulty with sucking and swallowing may be early signs of a heart condition. Now, I want you to use the critical test strategies here. And I want you to focus on the word feeding difficulties. All right. Another is 2-week-old infant. And there's that word suspected ventricular septal defect and the phrase before responding. These all indicate that the nurse needs to assess the situation based on the medical condition. All right, which is the VSD, not just the normal course of infant feeding. And I want you to look for that answer that focus on the possibility of heart-related issues. Since the infant has a suspected heart condition, I want you to focus on how the feeding difficulties might be related to a cardiac problem, such as heart failure or maybe poor circulation, both of which can affect feeding. And now the correct answer here is letter D. And why is that? It's because feeding difficulties such as trouble sucking or swallowing can be early signs of a heart problem like ventricular septal defect. Now, I want you to recall that in ventricular septal defect, the blood flow is impaired, which can lead to fatigue during feeding, can cause cyanosis. There's going to be poor weight gain due to the decreased cardiac output. And these signs reflect the heart's inability to adequately pump blood during increased activities such as feeding. And so letter A is incorrect. And it's because, like we know that feeding difficulties may be common in newborns, but persistent feeding problems after the first few days of life are typically abnormal. And this should raise concern, especially when there is a suspected heart defect. Okay, and I want you to consider that feeding difficulties that persist, like the ones reported in this case, often indicate an underlying problem, especially when the infant is already at risk for a cardiac issue. Now, letter B, another incorrect option here, and that is because we know that mucus retention may briefly affect feeding in some neonates, but it does not typically last for several weeks. And to add to that, it doesn't explain persistent feeding issues at 2 weeks of life. Given the suspected VSD, the nurse here should consider cardiac involvement rather than focusing on mucus retention as a primary cause of feeding issues. We have letter C as our last option, and this is also incorrect because insufficient sucking is concerning itself. We know that, particularly in a neonate with a suspected heart condition. And we know that cyanosis is a key sign of a severe cardiac issues, but the failure to feed properly can be an early indicator of fatigue and ineffective circulation due to the poor cardiac output. And so delaying the response until the cyanosis is observed could be detrimental to the infant's health. Now, I want you to use the test-taking strategy here. I want you to focus on underlying medical conditions. So when there is a specific condition like VSD, whenever it's mentioned, you need to be mindful that cardiac issues can lead to feeding difficulties, especially in neonates. And also to consider how heart problems might affect cardiac output and the oxygenation during the feeding. And don't neglect to look into signs of serious conditions. And in this case, a failure to feed well could be a sign of more than just a normal newborn behavior. And I want you to be sure or to note that feeding difficulties are often linked to pathological causes in neonates, especially with an existing suspected heart defect. Alrighty, let's have number 54. A client is taking carbamazepine Tegretol for trigeminal neuralgia. What should the nurse assess to determine if the medication is effective? A. Occurrence of seizures. B. Heart function. C. Liver enzyme levels. And D. Degree of pain or relief. Now, this question revolves around the use of the medication Tegretol. This is intended for the trigeminal neuralgia, which is a condition that is characterized by severe facial pain. And the goal here is to assess the effectiveness of the medication. So I want you to pay close attention to the answer choices that directly relate to the desired effect of the drug specific to the condition. All right. Now, what is the answer here? That would be letter D. It's because carbamazepine is used primarily for its analgesic effect in trigeminal neuralgia. Now, I want you to remember that carbamazepine is actually an anticonvulsant or it's an anti-epileptic drug, but it's also widely used for neuropathic pain medication, especially for this condition. And the drug action, actually, it's going to calm overactive nerve signals, basically preventing those very sudden, severe jolts of pain that trigeminal neuralgia is known for. And think of the medication as a sodium channel blocker. It will help stabilize the nerve cells so they don't misfire as easily. And the primary goal of the therapy is to control pain caused by the nerve irritation. And the nurse should assess how well the pain is managed, as this indicates the effectiveness of the drug. Now, we have letter A as one of the incorrect options here, occurrence of seizures. Even though the medication itself is an anticonvulsant, and this is used to treat seizures, but in this case, carbamazepine is used for a different reasons. And seizures are not a symptom of trigeminal neuralgia. Again, your focus here should be on the pain relief, not seizure control. And so the occurrence of seizures would not be the most relevant indicator of carbamazepine's effectiveness for this condition. Letter B is also incorrect, heart function, because carbamazepine does not have a primary effect on cardiac function in the context of trigeminal neuralgia. We know that it has some cardiovascular side effects. Also, monitoring heart function, it is not the best measure of its therapeutic success in pain management for the trigeminal neuralgia. Letter C, another incorrect option. Here, it's because the carbamazepine, we know that it can cause some hepatic side effects. It can lead to liver toxicity. Monitoring the liver enzyme levels is done to assess for the adverse effects rather than to determine whether the medication is effective in treating trigeminal neuralgia. And so effectiveness in this sense would be better gauged by assessing pain relief rather than the liver function. So I want you to focus on the condition being treated. And in this case, the medication is prescribed for Tegretol, which is characterized by the severe facial pain. And I want you to look for an option that focuses on pain relief, or let's say outcomes directly related to the condition. So I want you to eliminate answers that focus on side effects or unrelated effects of the drug, such as liver enzyme levels or heart function that refer to monitoring for the adverse effects, rather than measuring the effectiveness of the medication. Let's have 55. A client with type 2 diabetes has been diagnosed with gout and is prescribed allopurinol xyloprim. What guidance should the nurse provide regarding this medication? A. This drug should be taken on an empty stomach. B. The dosage of oral diabetes medications will need to be increased. C. A widespread red rash is a common side effect. D. It is important to consume 2 to 3 liters of fluids daily. This question is testing your knowledge about the medication allopurinol, which is used for gout, and how it interacts with other medications used in type 2 diabetes. That is your clue right here. And this question is also testing whether you understand nursing teaching points and side effects. Now, the answer here is letter D. And why is it? Well, the key reason for this instruction, it said here, hang on, letter D. It is important to consume 2 to 3 liters of fluids per day. And the key reason for this instruction is that allopurinol can lead to kidney stone formation by increasing uric acid excretion by the kidneys. And so drinking enough water can help flush out uric acid. It can reduce the risk of crystal formation in the kidneys. And so this is a key safety measure, and that's why it is the best choice. Why is letter A incorrect? This drug should be taken on an empty stomach. Why is it incorrect? Well, allopurinol can irritate the stomach if taken without food. So your instruction here instead would be to take the medication with food or milk to prevent gastric discomfort. And so my tip for you in ruling out this item or this option is to look out for absolute phrases like should be taken, phrases like should be taken on an empty stomach. Many meds are better tolerated with food, right? Now, letter B is also incorrect because allopurinol enhances the effects of oral diabetes medications. Take a look at here. And these are the medications such as sulfonylureas and other hypoglycemic agents. This can actually lead to a greater risk of hypoglycemia. And so this statement right here will need to be increased is making this option incorrect. So instead of increasing the dose by the provider, of course, they're supposed to decrease it to prevent hypoglycemia. And the phrase will need to be increased. It is a red flag. If you're unsure, always think about how drugs interact before assuming an increase or decrease in the dose. Now, what about letter C? Widespread red rash is a common side effect. This is very wrong. It's because a red rash is not just a common side effect. It can be a serious allergic reaction such as Stevens-Johnson syndrome or toxic epidermal necrolysis. And so if a rash develops, the medication may need to be stopped immediately. And so the common phrase, it is a common side effect in this context, is misleading. So if you see an answer downplaying a potentially dangerous reaction, that's a clue that it is incorrect. All right, let's have number 56. While receiving an oxytocin-pitocin infusion for labor augmentation, a client experiences rupture of membranes and the fetal monitor shows variable decelerations. What should be the nurse's next action? A. Prepare the client for an immediate delivery. B. Stop the oxytocin infusion. C. Check the client's blood pressure. D. Reposition the client. Now, when you encounter a question like this, it's very crucial to think about the fetal heart rate patterns and how they relate to the potential causes. And in this scenario, you're specifically dealing with variable decelerations, which are often related to umbilical cord compression. Now, the key here is to identify interventions that will address the cause of the decelerations rather than focusing on unrelated factors. So the answer here is letter D. Why is this correct? It's because variable decelerations are most commonly caused by umbilical cord compression. And so changing the mother's position can help relieve pressure, especially repositioning to the left side. Okay, this can relieve the pressure on the umbilical cord, which is often the underlying cause of these decelerations. So a simple repositioning, such as moving the client to the left side or into a hands and knees position, is a first-line intervention, and this can significantly improve fetal heart rate patterns. Now, what about letter A? This is one of the incorrect options here. Prepare the client for an immediate delivery. This is incorrect because we know that variable decelerations are concerning. They don't necessarily mean that immediate delivery is required. Your first response here should be to address the cause of the deceleration, which is likely cord compression. So rather than rushing to prepare the patient for delivery. And immediate delivery is typically indicated when there are signs of fetal distress or non-reassuring fetal heart patterns that don't respond to initial intervention. So discard this option. Why is letter B incorrect? Stop the oxytocin infusion. The reason for that is because variable decelerations are not typically related to the oxytocin infusion. Again, the variable decelerations are more likely caused by cord compression, and stopping oxytocin would only be necessary if there was excessive uterine stimulation or tachysystole, which is not indicated by the information in this case. And also stopping oxytocin could be appropriate in other situations, but it is not the first line action for addressing variable decelerations. What about letter C? Another incorrect option here. It's because blood pressure changes are not the cause of variable decelerations. These decelerations are typically related to umbilical cord compression, not maternal hypertension. And so checking the blood pressure might be useful in other scenarios if you suspect preeclampsia, but it's not relevant to the immediate management of variable deceleration. So for you to answer this question correctly, I want you to focus on the fetal heart rate pattern. And the key word again here, the key words are variable decelerations, which is going to suggest that there's umbilical cord compression as a likely cause. And when you see these decelerations, you think about interventions that can relieve cord compression, and that would be repositioning the client. And again, the repositioning here is quite hidden, but specifically it's talking about left side lying position. Let's have number 57. Which of the following congenital heart defects are characteristic of Tetralogy of Fallot? A, abnormal connection between the pulmonary artery and the aorta, right ventricular hypertrophy and an atrial septal defect. B, right ventricular hypertrophy, defects in both atria and ventricles, and mitral valve stenosis. C, the aorta originates from the right ventricle and the pulmonary or artery originates from the left ventricle. D, right ventricular hypertrophy, ventricular septal defect, pulmonic stenosis, and overriding aorta. Now the question focuses on congenital heart defects, specifically the TOF. And when you come across such question, I want you to recall the key features of the common congenital heart defects, and I want you to recognize them in the options. Now, why is letter D the answer to this question? It's because Tetralogy of Fallot is characterized by 4 main defects, and these are the ventricular septal defect. There's also an opening between the left and the right ventricles. And the other thing is the client here will have pulmonic stenosis, right? There's going to be narrowing of the pulmonary valve or artery, which increases the resistance to the blood flow. There is also overriding of the aorta. And the aorta is positioned directly over the ventricular septal defect. and receiving blood from both ventricles. And there's also right ventricular hypertrophy. Okay. And so the right ventricle becomes enlarged, also thickened due to the increased effort needed to pump blood through the narrowed pulmonary artery. Okay, so it's actually causing more stress into the right ventricle. And so that's why it's called Tetralogy of Fallot. Okay, so it will impair oxygenation. It can lead to cyanosis in the affected individual. Now, why is letter A incorrect here? It's because Tetralogy of Fallot does not involve an abnormal connection between the pulmonary artery and the aorta, or it doesn't involve atrial septal defect. All right. And I want you to remember that atrial septal defect, or ASD, is not part of TOF, but it could be present in other congenital heart defects. What about letter B here? Okay, so this is also incorrect. And the reason for that is because the Tetralogy of Fallot does not involve defects in both atria and ventricles, nor does it involve mitral valve stenosis. And the features mentioned here are seen in other heart conditions such as hypoplastic left heart syndrome or maybe atrioventricular septal defects. Letter C, another incorrect option. This is because this group of disturbances here, or abnormalities, describes the transposition of the great vessels, not TOF. And I want you to remember that in transposition of the great vessels, the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle, which is a completely different congenital defect from the Tetralogy of Fallot. Again, the word transposition of great vessels. So basically there is a anomaly. There is a mix up between the great blood vessels. Instead that the aorta is arising from the left ventricle, now it's actually originating from the left ventricle. And the pulmonary artery this time in this option is basically arising from the left ventricle instead of the right ventricle. So that is what we call as transposition of the great vessels. Now, to answer this question, if you are not that quite familiar, I want you to focus on the key terminology. So when you recall the congenital heart defects, the names of the defects themselves are often descriptive. And so, for example, in TOF, the word tetra refers to the 4 defects. And when you answer, you got to focus on the 4 main defects: the VSD, pulmonic stenosis, overriding aorta, and right ventricular hypertrophy. And I want you to use the acronym PROV, PROV. So PROV stands for, the P stands for pulmonary stenosis, or the narrowing of the pulmonary valvular artery. The R represents for right ventricular hypertrophy, where there is thickening of the right ventricle's wall. And O represents the overriding aorta. The aorta is positioned over the ventricular septal defect instead of over the left ventricle. And the V, ventricular septal defect, which is a hole in the wall between the 2 lower chambers of the heart. And don't forget PROV to remember the Tetralogy of Fallot. Let's have 58. A client with a history of seizures is receiving phenytoin, dilantin, and heparin for a deep vein thrombosis. Warfarin is added as a heparin is being discontinued. Why must the nurse closely monitor the client during the initial days of warfarin therapy? Letter A, phenytoin reduces warfarin's ability to prevent clot formation. B, seizures speed up warfarin metabolism, decreasing its effectiveness. C, warfarin has a stronger effect on clients with seizure disorders. D, warfarin influences how phenytoin is broken down in the body. So I want you to break this question down. And also the question is involving the interaction between phenytoin and warfarin and the heparin, which is important in pharmacology, especially when you're managing clients with multiple medications. So a helpful strategy is to recall how different meds can influence the metabolism of one another, particularly focusing on the drug interactions. And so when you see terms like phenytoin, warfarin, heparin, you need to consider their known interactions and how they can affect a patient's therapy, especially during the initiation of a new drug. The answer to this question is letter D. Warfarin influences how phenytoin is broken down in the body. Now, this is correct because warfarin has been shown to inhibit the metabolism of phenytoin dilantin. And when warfarin is introduced to a client who is already taking phenytoin, it will cause an accumulation of phenytoin in the body, which may lead to phenytoin toxicity. And so this interaction is important to monitor, as elevated phenytoin levels can increase the risk of side effects. It can lead to neurological symptoms such as dizziness. There's going to be nystagmus or ataxia. Letter A here is incorrect because phenytoin does not reduce warfarin's anticoagulant effect. And in fact, phenytoin can actually decrease the effectiveness of warfarin by inducing liver enzymes that metabolize warfarin, though the focus here is on warfarin's effect on phenytoin, not the reverse. Okay? And letter B here. This is also an incorrect option. Why is that? It's because seizures do not affect the metabolism of warfarin. It's actually certain drugs such as phenytoin that can influence the metabolism of warfarin. And the focus here is on the drug-drug interaction, not the direct effect of seizures on warfarin metabolism. Letter C, another incorrect option here. It says warfarin has a stronger effect on clients with seizure disorders. And the reason for that is because warfarin's effectiveness is not directly related to whether a client has a seizure disorders, and the warfarin's anticoagulant action is the same regardless of the patient's seizure history. And so this option is misleading, as warfarin's effects are not modified by seizures disorders. And so here we are inviting you to enroll to the NCLEX course via sankosnclexcoaching.com. So I want you to do a quick visit. Let's have test item number 59. A client is being treated with albuterol Proventil for acute asthma symptoms. What potential side effects should the nurse monitor? Select all that apply. A, slower heart rate. B, irregular or rapid heartbeats. C, extreme fatigue. D, uncontrollable shaking. E, blurred vision. So this question is asking about the potential side effects of the Proventil, which is a beta agonist used to treat acute asthma symptoms. Now, I want you to recognize the common side effects associated with sympathomimetic drugs such as albuterol, right? And so sympathomimetics typically can stimulate the sympathetic nervous system, which affects multiple body systems. And the answers that we have here are the following. These are your letters B and D, irregular or rapid heartbeats, and uncontrollable shaking. Now, let's take a look into letter B. This is correct because albuterol works as a sympathomimetic. It stimulates the sympathetic nervous system, which can lead to rapid heartbeat. It can cause palpitations. And this happens because the albuterol activates the beta-2 adrenergic receptors in the lungs, but also has some effect on the heart's beta-1 receptors, which can cause these cardiac effects. It can also lead to the irregularity of the rhythm, right? And letter D, uncontrollable shaking. This is correct because albuterol stimulates the central nervous system, which can lead to tremors. And again, this is a known side effect due to the CNS stimulation caused by the sympathetic action of the albuterol. It can result to restlessness, anxiety, nervousness. Why is letter A incorrect here? It's because albuterol actually causes the exact opposite. All right? It will stimulate the heart, so not slowing the heart rate. What about letter C? Extreme fatigue. It's because albuterol is more likely to cause restlessness, irritability, or anxiety due to its stimulating effect on the central nervous system, not fatigue. And again, fatigue is not a common side effect of albuterol. Rather, it tends to cause more agitation or nervousness. Letter E, another incorrect option. It's because blurred vision. Again, it's not a typical side effect. And the albuterol here can cause dizziness or a feeling of lightheadedness due to its vasodilatory effects. But visual disturbances are not commonly reported. And so this could be related to other conditions or other medications. So when you answer this question, I want you to identify the drug classification and the mechanism of action. And again, recall that this is a sympathomimetic beta agonist. And this will cause stimulation of the sympathetic nervous system. There's going to be increase in the heart rate, tremors. This can lead to restlessness. And I want you to focus on key terms: sympathomimetics, tachycardia, tremors. These are very strong clues, and you need to eliminate those unlikely symptoms. So if it's not going to fit with the known effects of the sympathomimetic drug, such as fatigue or blurred vision, you need to eliminate those. Let's have number 60. A client is experiencing an arthritis flare-up. What nursing actions can help prevent knee deformities? Select all that apply. A. Position joints in proper alignment while the client is resting. B. Encourage extended periods of bed rest. C. Promote movement of the affected joint. D. Keep the joint stabilized with pillows until pain diminishes. E. Apply a knee brace to provide comfort. So the question here is about arthritis flare-ups and preventing knee deformities. So when you encounter this type of question about arthritis or joint issues, it's helpful to recall that maintaining joint mobility and preventing immobility are very crucial to prevent the deformities, especially in inflammatory conditions such as the arthritis. So I want you to focus on the key terms: proper alignment and also movement stabilization. So I want you to go navigate into the options as well. Now, what are the correct answers to this question? One of those, or the answers here, are letters A and C. And why letter A? It's because maintaining proper alignment is crucial in preventing joint deformities, especially during rest. And when joints are kept in a functional alignment, it reduces stress and strain on the affected areas, which will prevent contractures and also prevent deformities that can occur due to the improper positioning over time. And letter A is a common recommendation for clients with arthritis to maintain joint health and functionality. Now, what about letter C? Promote movement of the affected joint. This is correct because joint movement is essential to prevent stiffness and the development of calcium deposits like bone spurs that can lead to deformities. So when you're encouraging the client to move the affected joint, this can help maintain the range of motion and also the muscle strength, which will reduce the risk of permanent deformities, and it can also maintain mobility. All right. Now, why is letter B incorrect? Encourage extended periods of bed rest. That is because bed rest leads to immobility, which can increase the risk of deformities and contractures. And take note that inflammatory arthritis can cause swelling and stiffness, but excessive rest can make these symptoms worse by reducing the joint's range of motion and increasing stiffness. The clue here that makes this option incorrect is extended periods. right? So it's very important to balance rest with appropriate movement to prevent these complications. Letter D, keep the joint stabilized with pillows until pain diminishes. A very incorrect option, because when you're immobilizing the joint for extended periods, such as keeping the joint stabilized with pillows, this can contribute to muscle weakness and the development of contractures, which are permanent joint deformities caused by shortened muscles and tendons. And we know that positioning the joint comfortably with pillows might help with pain relief, but it should not be done to the extent that it completely immobilized or stabilized the joint for prolonged periods. The key words here are until pain diminishes. Yes, pay attention to the clue here. Now, what about letter E? Apply a knee brace to provide support. This is also incorrect, because we know that a knee brace may provide a temporary support, but it can also contribute to the immobilization, can lead to muscle atrophy and also reduced joint flexibility if it's used too often. So it's better to encourage movement and avoid relying on a brace unless it's part of a specific treatment plan. Again, unless it's part of a specific treatment plan from the healthcare provider. So for you to answer this question correctly, I want you to focus on mobility versus immobilization. So with this type of question, remember that movement is key to joint health, especially in arthritis, and you have to avoid those options that promote immobility, like bed rest or excessive use of pillows, because they can worsen stiffness and can lead to deformities. Again, the clue words here: extended periods. We have keep the joint immobilized or stabilized until pain diminishes. So these are things that are actually red flags. So always aim for maintaining or promoting joint motion. And so you need to also look for terms like alignment, movement. So if you see options involving proper alignment or joint movement, these are likely to be correct. And take note that proper alignment reduces strain, and movement prevents stiffness and deformities. So these are key principles in managing arthritis flare-ups. And again, eliminate unnecessary immobilization. If it involves immobilizing the joint too much, especially pillows or excessive rest, it's usually incorrect. Now, let's have number 61. A middle-aged male adult client is brought to the emergency department by friends due to increasingly erratic behavior. Which specific signs should the nurse assess that could indicate cocaine use? Select all that apply. A, heightened alertness. B, restlessness. C, intense happiness. D, episodes of panic. E, impaired decision making. F, slurred speech. So the question is wanting you to assess signs of cocaine use. And when it comes to drug-related questions, it's helpful to remember that each substance has distinct effects based on whether it is a stimulant, such as this one, this is cocaine, or a depressant, such as opioids. Now, I want you to recall that cocaine is a stimulant. It can cause euphoria, hypervigilance, there's going to be agitation, and impaired judgment. So I want you to look for the clues in the options that describe increased activity, there's hyper alertness, or emotional extremes, which are typical for the use of a stimulant. And so the correct options here are letters A, B, C, and E. And why letter A? It's because cocaine, again, is a stimulant that can cause hypervigilance or heightened alertness. And people who are intoxicated with cocaine may become excessively aware of their surroundings, often appearing jittery or very on the edge, which is a classic sign of stimulant use. There is also restlessness because cocaine increases the activity of the neurotransmitters like dopamine and norepinephrine, which leads to agitation and restlessness. And so cocaine users often have difficulty staying still, and they may appear nervous or overly energetic. Now, what about letter C, intense happiness? This is also correct because euphoria or intense happiness is another hallmark of cocaine intoxication. This can cause a rush of dopamine in the brain. This can lead to extreme feelings of pleasure and euphoria, which can make the user feel exceptionally happy or overjoyed for a period of time. Letter E, another correct option, because cocaine can impair their judgment and their decision making. And when individuals are intoxicated with cocaine, they will often make risky decisions. They feel overly confident, and they also exhibit poor judgment due to the stimulating effects of the drug on the brain's dopamine pathways. Now let's tackle the letters D and letter F, which are the incorrect options. So let's have letter D, episodes of panic. This is incorrect because panic attacks, all right, are more commonly associated with hallucinogens or anxiety disorders, not specifically with cocaine use. And we know that cocaine can cause anxiety. It doesn't usually lead to the panic attacks that are seen with hallucinogens like LSD or the PCP. Slurred speech is another incorrect option because it's typically associated with opioids or alcohol, which are depressants that can slow down the central nervous system. And again, the cocaine is a stimulant. It doesn't cause slurring speech. All right. In fact, it can lead to overactivity and talkativeness rather than slurring of their words. So for you to answer this question correctly, I want you to focus on the class of the substance. It is a stimulant. Okay. So the effects are usually increased activity. There's euphoria, hyper alertness. And if you see options like restlessness, heightened alertness, intense happiness, these are good indicators of cocaine intoxications, right? Let's have 62. With the cervix fully dilated and effaced and the fetal head at a +2 station, what breathing or pushing strategy should the nurse encourage the client during contractions? A, instruct the client to push while keeping her glottis open. B, advise her to relax and close her eyes. C, recommend that she pant during contractions to reduce stress on the cervix. D, suggest that she blow gently to slow down the delivery process. All right, so when you encounter this question about labor and delivery, especially in the second stage of labor, you need to think about the expulsive nature of the contractions and the need to assist in the fetal expulsion. Now, I want you to remember that in this stage, the goal is to help the mother push effectively and also to manage the intense contractions. So you better pay attention to the station of the fetal head and focus on what the client needs to do to help the delivery process move along. And so the correct answer here is letter A. Okay. The reason why it's correct is because in the second stage of labor, this is when the cervix is fully dilated, right? And effaced. And the fetal head is at +2 station. So pushing is essential to help expel the fetus. And when you're encouraging the client to push with an open glottis, this helps avoid excessive strain, and it can also reduce the risk of perineal damage. And this is also a more effective technique that can hasten the expulsion of the fetus. And so the open glottis technique also prevents Valsalva maneuver. Again, it prevents Valsalva maneuver, which can elevate the blood pressure, and it's more comfortable and it's also physiologically appropriate during the active pushing. Now, why is letter B incorrect here? Advise her to relax and close her eyes. Why is that incorrect? It's because at this stage of labor, relaxation is not practical during contractions. The client is in the midst of the expulsion phase, and relaxation generally occurs between contractions rather than during them. And encouraging relaxation during contractions would not be helpful, as the need to focus on pushing at this point. Right. And so let's have letter C. Why is this incorrect? It's because panting itself is typically used during the latent phase of labor, which is the early stage. And this is to help the mother manage pain and prevent pushing when she's not ready. And so panting here can actually reduce the effectiveness of pushing in the second stage of labor. And this should not be encouraged until the fetal head crowns, which is around 4+ or +4 station. And the purpose here is to support the expulsion phase, not to delay it. Now, letter D is also incorrect. It suggests that she blow gently to slow down the delivery process. Big incorrect here, because blowing gently is another method to it's another method to slow down the pushing process in order to help prevent too rapid delivery. But in this case, the cervix is already fully dilated and the fetal head is at +2 station. And so the aim at this stage is to, again, encourage effective pushing. And so for you to answer this question correctly, I want you to focus on the stage of labor. And the question is specifically asking, it's stating that the cervix is dilated and the fetal head is at +2 station, which means we are in the second stage of labor, the stage of expulsion. And again, the goal here is to facilitate and also to assist the mother in the expulsion of the fetus. All right. And again, I want you to remember that techniques for effective pushing, the open glottis technique is associated with better outcomes during the pushing, and it will avoid excessive strain on the perineum, and it can also prevent the Valsalva's maneuver. All right. So think about the benefits of having this technique. Let's have 63. A 1-month-old baby is brought into the pediatric ward with a possible case of Hirschsprung's disease. To verify this condition, which diagnostic test would the nurse anticipate being ordered? A. Rectal biopsy. B. Colonoscopy. C. Multiple saline enemas. And D. Fiber optic nasoenteric tube. And when you answer this question about pediatric conditions, especially Hirschsprung's disease, it's critical to focus on the diagnostic accuracy, and you need to recognize the specific tools used to diagnose that condition. And I want you to remember that Hirschsprung's disease is caused by the absence of the ganglion cells in the intestines. And the key to this question lies on recognizing that definitive diagnostic test. And so the correct answer here is letter A. Why letter A? It's because the rectal biopsy is the gold standard for diagnosing this disturbance. And the test involves taking a full thickness biopsy of the rectum, which is then going to be examined microscopically for the absence of the ganglion cells, those cells that are essential for proper bowel function. And so if there's no ganglion cells, or if there's absence of the ganglion cells, the intestine cannot properly move the stools. It can lead to the symptoms of this disorder. Now, why is letter B incorrect? We know that colonoscopy is useful in diagnosing so many intestinal conditions, but in this case, it's not going to be helpful. We know that colonoscopy allows the gastroenterologist to view the intestines, but it does not provide tissue samples for confirming the presence or absence of ganglion cells. And so it is not the correct test for confirming Hirschsprung's disease. Okay. What about letter C, multiple saline enemas? This is incorrect because saline enemas may help relieve the obstruction caused by the Hirschsprung's disease temporarily, but will not diagnose the condition. Okay. So The barium enema instead, which is a diagnostic imaging, may be used in older children, but it's not, again, the first choice for diagnosing Hirschsprung's disease in an infant, and it is not a definitive test. And what about the fiber optic nasoenteric tube in letter D? Another incorrect option, because this is something that's primarily used for feeding or drainage purposes. Again, this is not a diagnostic tool for this disturbance, and the purpose of this tube is to help feed or remove fluids, and not to diagnose conditions related to intestinal obstruction. So for you to answer this question carefully, I want you to look for the clues. The key word here is to, right here, verify. It's asking for the diagnostic test, not a treatment, not procedure that could relieve symptoms. All right. It's asking for a diagnostic test to identify the cause of the problem. All right. Also, the 1-month-old words, it also suggests that we are dealing with a pediatric condition. So focus on the tests that are used specifically in infants. Now, I want you to eliminate the non-diagnostic procedures, such as questions like this, of course, will often have a mix of correct and non-diagnostic options. So I want you to eliminate choices like saline enemas or nasoenteric tubes. These are not used to definitively diagnose the Hirschsprung's disease. All right. So let's have number 64. A client with arthritis is experiencing an episode of right-sided heart failure and is prescribed furosemide Lasix. The healthcare provider reduces the client's usual aspirin dosage. When the client asks why, what is the nurse's most appropriate response? A, taking furosemide and aspirin together can lead to an accumulation of uric acid in the kidneys. B, aspirin speeds up the breakdown of furosemide, reducing its diuretic effectiveness. C, both drugs compete for kidney excretion, which can raise aspirin levels in the blood. D, high doses of aspirin after a major stress event can increase the risk of bleeding. Now, when you are tackling drug interactions questions, it is crucial that you have to focus how medication interact at the physiological level, especially when it comes to their metabolism and the excretion. And in this question, you're looking for the responses that accurately reflects Lasix and aspirin interact within the body. So I want you to pay close attention to the terms kidney, excretion. There's also toxicity, metabolism. So these are going to point out to the crucial interaction information. Now, what is the correct answer here? The answer is letter C. This is correct because furosemide or Lasix and aspirin are both eliminated through the kidneys. They are excreted the kidneys. This is the major route where they can be expelled by the body. And so when they are taken together, they are going to compete for the same renal excretory pathways. So this can lead to increased aspirin levels in the blood. So what's going to happen here? It will result to salicylate toxicity, even if the aspirin dosage is reduced. So you need to understand the concept of drug competition for renal excretion here. What about letter A? This is incorrect because furosemide does not directly cause the accumulation of uric acid when combined with aspirin. Although we know that furosemide can increase uric acid levels, but the main concern here is how the two drugs compete for excretion, not about the formation of uric acid crystals. And the correct concern is the risk of salicylate toxicity, not uric acid accumulation. Now, letter B, another incorrect option here. And why is that? That's because the aspirin does not affect the metabolism or breakdown of furosemide. So this statement alone is misleading because it incorrectly suggests that aspirin would make furosemide less effective, But in reality, furosemide's diuretic effect remains unchanged. But the concern here is about competing excretion in the kidneys, not a direct effect on the breakdown of the drug. What about letter D? Another incorrect option. So this is incorrect because this answer focuses on the issue with aspirin and bleeding risk, which may be relevant in some cases, but it does not address the interaction between the aspirin and the furosemide. And the question specifically asks why the aspirin dosage is being reduced in the context of furosemide use. So the focus should be on the kidney excretion competition rather than the bleeding risk. Now, for you to answer this question correctly, I want you to look for the clues in the question. The key phrase here is prescribed furosemide and the reduced aspirin dosage. Okay, this one right here. So this suggests you're dealing with a drug interaction question. So focus on the mechanisms of excretion, and you have to recall about kidney function and how the two drugs can interact at that level. Okay, so let's have number 65. Before undergoing surgery for open reduction and internal fixation of a hip fracture, the client is placed in traction to stabilize the bone. Since the client keeps sliding down in bed, additional counter traction has been prescribed. What action should the nurse take to increase counter traction? A, secure a chest restraint around the client. B, lower the head of the bed slightly. C, increase the traction weight. D, raise the head of the bed. Now the answer here is letter B, lower the head of the bed slightly. The reason for that is because lowering the head of the bed slightly places the client in the Trendelenburg position. And this position uses gravity and the client's weight to help increase counter traction, which will help keep the client from sliding down in bed. And remember that gravity plays a crucial role in the counter traction. So this positioning maneuver can use the body's natural weight to counterbalance the traction force pulling the body in the opposite direction. Why is letter A incorrect here? Secure a chest restraint around the client. The reason for that is that chest restraints are not a solution for counter traction. And the restraints may prevent movement, but they don't address the mechanics of counteracting the force applied by the contraction. And so the goal here is to use the gravity and the body weight for effective counter traction, not restraint. Letter C, increase the traction weight. Another incorrect option, because when you are increasing the traction weight, this will increase the pulling force, but it won't increase counter traction. Now, I want you to remember that counter traction is not dependent on the amount of traction weight, but rather on how the body is positioned and how it's aligned to counterbalance the traction force. And adding more weight to the traction could be dangerous, and it's not the right way to address the issue of sliding down in bed. What about letter D, raise the head of the bed? Another incorrect option, because when you're raising the head of the bed, it actually decreases counter traction because it would encourage the client to slide further down due to the gravity working in the opposite direction. And in order to increase counter traction, you need to lower the head of the bed, not raise it. And so the strategies that you need to use here would be to look for the keywords counter traction or positioning in the question to guide you toward a correct answer. Okay, so take a look here in this phrase. Additional counter traction has been prescribed. Now, also counter traction is basically the force that works against the traction to keep everything in place. So think of it as like a tug of war. Traction pulls in one direction and the counter traction holds things steady so the bone stays aligned. And In most cases, the client's body weight provides natural countertraction, but if the person here is sliding down in bed more frequently, that means we need to adjust something to keep the balance. Now, in order for you to capture everything here, I want you to understand the mechanics of the situation. Again, in traction, the goal is to apply a pulling force to stabilize the bone, whereas the counter traction can help balance that force to keep the body in place. And so the Trendelenburg position, as the answer to this question, uses the client's body weight to enhance the counter traction. 66. A client with trigeminal neuralgia, tic douloureux, is being assessed by the nurse. Which clinical findings are expected? Select all that apply. A. Increased talkativeness due to nervousness and distress. B. Fatigue and exhaustion resulting from severe pain. C. Extended periods of sleep related to anxiety. D. Poor nutritional intake caused by fear of triggering pain. E. Heightened activity levels due to prescribed medications. And so when you are answering this type of question about trigeminal neuralgia, it's very critical to understand the key symptoms, the manifestations of the conditions, especially the painful attacks, which is triggered by the simple stimuli like chewing on food, talking, touching. So those are the things that you need to remember about this disorder. And the key to answering correctly is to recognize what clinical manifestations are expected due to the pain and fear of triggering attacks. So you need to look for answers that mention pain, avoidance of the stimuli, and fatigue. So these are the hallmarks of this condition. And so the correct answers here are letters B and D. Why B, fatigue and exhaustion? It's because the trigeminal neuralgia is known for the severe, intense pain that comes in short bursts. It's often triggered by touch, talking, chewing, or other light stimuli. Even if you're the nurse walking past the patient, this can trigger the intense pain. And this can be so debilitating that it can lead to fatigue. It can cause them exhaustion due to the constant stress of dealing with the pain. And the emotional stress and muscle tensing associated with the attacks can further contribute to the fatigue. Letter D is also a correct option here because the fear of triggering pain from chewing or swallowing makes clients avoid eating. And so chewing or swallowing can trigger the excruciating pain of trigeminal neuralgia. So many patients become fearful of eating or drinking. And so this can lead to poor nutritional intake. So the other options here, such as letter A, is incorrect. It's because people with trigeminal neuralgia are often very quiet to avoid triggering pain from talking. And the condition is so painful that speaking may be avoided altogether. And instead of being talkative, the person may be withdrawn or they become hesitant to speak, anticipating pain. C is also incorrect because people with the tic douloureux are more likely to experience disturbances in their sleep due to the pain rather than extended periods of sleep. And the pain can also disrupt their ability to sleep, and they may be very quiet during the day to avoid triggering an attack. And the anxiety about potential pain may lead to difficulty falling or, let's say, staying asleep rather than inducing sleep. Letter E, another incorrect option here. It's because the medications for the trigeminal neuralgia, like anticonvulsants, I want you to recall about the carbamazepine Tegretol, do not increase activity levels. These medications are actually indicated to reduce the pain and also to control that condition. And so hyperactivity is not a typical side effect of these drugs. And so if anything, patients may be more likely to be inactive due to pain or medication side effects like drowsiness. Now, I want you to use the strategy here to answer this question correctly. I want you to look for the key symptoms of the trigeminal neuralgia in the question, such as severe pain, fear of triggering attacks, and the impact on the daily activity. So this can help you focus on the options that directly relate to the challenges faced by the clients with tic douloureux. And I really want you to strengthen your knowledge about the pathophysiology about this condition if you are not familiar with tic douloureux. Again, trigeminal neuralgia is characterized by excruciating, sharp, and shooting pain in the face, and this are triggered by things like touching the face, talking, chewing, or even a slight breeze of air. And so this explains why patients may avoid talking, avoid eating, or even avoid socializing. And fatigue and poor nutrition are common outcomes due to the pain and the fear of triggering the attacks. 67. So again, we are inviting you to enroll to the NCLEX course. So kindly visit sandcoastnclexcoaching.com. And we have all these perks right here. So let's proceed to question number 67. When taking the health history, what question should the nurse ask a client who is being admitted to rule out infective endocarditis? A, do you take any non-steroidal anti-inflammatory medications? B, is there a history of rheumatic heart disease in your family? C, have you ever had a heart attack? D, have you ever had a cardiac valve replacement surgery? And so when you're asked with a type of question like this about infective endocarditis, you need to focus on identifying the risk factors that increases the likelihood of this condition. And so the key risk factors often include prior heart surgeries, cardiac valve issues, or invasive procedures, because these directly affect the heart structure and increase the chances of infection. And so the phrase to rule out infective endocarditis, it's a crucial clue. It will prompt you to consider risk factors for infection that would affect the heart's valves or their structure. And so the correct answer here is letter D. It's because cardiac valve replacement surgery is a significant risk factor for infective endocarditis. And I want you to recall that after a valve replacement, the new valve can become a site for bacteria to adhere to, and it will cause infection, especially if there is any bacteremia. And this is why patients who have had valve replacement surgeries, they're often prescribed prophylactic antibiotics before invasive procedures like dental work to prevent infective endocarditis. So this makes the question relevant to identifying the risk factor that could lead to the condition. Now, what about letter A? This question is incorrect because NSAIDs do not contribute to the development of infective endocarditis. We know that NSAIDs can affect blood clotting and inflammation, but they don't directly influence the risk of bacterial infection on heart valves. And this question in option A doesn't target a known risk factor for infective endocarditis. Letter B, another incorrect option here. It's because rheumatic heart disease is a condition that results from a history of rheumatic fever and not necessarily a family history of it. It's a personal history, not family histories, that plays a role in increasing the risk of infective endocarditis. And I want you to remember that rheumatic fever can damage heart valves, setting the stage for the potential infection. So the focus here should be on personal medical history rather than family history. Letter C, another incorrect option, because the heart attack is not directly linked to an increasing risk of infective endocarditis. We know that heart attack can cause damage to heart tissue, can lead to complications like heart failure, but it is not a direct risk factor for developing infective endocarditis, which is caused primarily by bacterial infections affecting the heart valves. So I want you to strategize in answering this question. You need to focus on known risk factors for infective endocarditis. And again, these include cardiac valve damage, surgeries like valve replacement, and conditions that can promote bacteremia or infections. Let's have number 68. A nurse is preparing to discharge a client recently diagnosed with asthma. Which statement indicates the client has understood instructions about using a peak flow meter? A, when I can't talk while walking, I should take my quick relief medication. B, if I'm in the red zone, I need to take my quick relief medication and avoid exercise. C, it takes 1 to 2 days to determine my personal best reading. D, if I'm in the yellow zone, I can continue my usual activities without using medication. So this question is asking you about the peak flow meter. Don't neglect this kind of question because this is commonly asked in the NCLEX. And this is an important device for monitoring asthma and also to determine how well the air is flowing out of the lungs. And the key here is to understand the color zones. We have green, yellow, red zones and their corresponding actions. And so the phrase indicates the client has understood instruction, clues you that the answer should reflect proper asthma management using the peak flow meter and understanding of asthma zones. And so the answer here is letter B. Okay, if I'm in the red zone, I need to take my quick relief medication and avoid exercise. This is correct because the red zone on the peak flow meter indicates a severe asthma exacerbation. And in this situation, the client should take quick relief or rescue medication immediately and should avoid exercise or any physical activity that could exacerbate the symptoms. And the red zone typically indicates that the airflow is significantly reduced, and it's critical for the client to take action to manage the symptoms and also to prevent further complications. Now, why is letter A incorrect? It's incorrect because difficulty talking or walking could be a sign of severe symptoms, but it is not the specific trigger for taking the medication according to the peak flow meter. Now, if a client is in the red zone, which is a key indicator for needing medication, that's when they should take their medication or quick relief medication. And so difficulty talking or walking could indicate an asthma attack, but it is more subjective and less reliable than the objective peak flow meter reading. Again, the use of peak flow meter is our clue here. Now, why is letter C incorrect? It's because the personal best peak flow reading is typically determined over the course of 2 to 3 days. Not 2 to 3 days, but 2 to 3 weeks, not days. Again, the personal best peak flow reading is typically determined over the course of 2 to 3 weeks, not just days. And so the client here should monitor their peak flow readings consistently during this period to establish their baseline or personal best, which can help them understand how their asthma is typically controlled. Letter D rather, is also incorrect. It's because when the client is in the yellow zone, it indicates that the asthma is not fully controlled and it requires action, and the client should use a long-term control medication as prescribed and monitor their symptoms more closely. And I want you to remember that yellow zone is a warning, and continuing their usual activities without taking medications could worsen the symptoms, and this will lead to an exacerbation of their asthma. So I want you to understand the meaning of the color zones first in order for you to effectively answer the questions. And so the peak flow meter works by showing the client their peak expiratory flow rate, or PFR, which can help them categorize the asthma status into the 3 color-coded zones. So as a review, the green zone in the peak flow meter, it means that there is good control. And so the client here can continue normal activities. Whereas when the patient is on the yellow zone, this is a caution. So the asthma is not fully controlled, and the client may need to adjust their medications according to the prescriber, right? And the red zone is a danger zone. So there is immediate action that will be required here, including taking quick relief medication and possibly an urgent medical attention here, or an emergency care. And so you need to focus on the key terms. The critical word here is a red zone, which points directly to the need for quick relief medication and also avoiding activities that could worsen the condition, such as the exercise. Let's have number 69. The nurse is asked by a client diagnosed with neurogenic diabetes insipidus, "What's going on with me? Why am I urinating so much?" What is the best response from the nurse? A, your kidneys are failing and you're producing too much urine. B, your thyroid gland is speeding up your metabolism. C, the islet cells of your pancreas aren't working properly. And D, your pituitary gland isn't releasing a necessary hormone. The answer is letter D. Why is letter D correct? It's because diabetes insipidus occurs due to a lack of the antidiuretic hormone, or ADH, which is primarily produced by the hypothalamus and stored by the pituitary gland. And so in neurogenic diabetes insipidus, the pituitary gland either produces or secretes insufficient antidiuretic hormone, or it fails to release it altogether. And so this can lead to the excessive urination because the kidneys cannot concentrate urine without ADH, or the antidiuretic hormone. All right. And so I want you to focus about neurogenic diabetes insipidus here. Why is letter A incorrect? The reason for that is because kidney failure can cause fluid imbalances, but it does not typically result in diabetes insipidus. And I want you to remember that in diabetes insipidus, the kidneys are not failing, but they are unable to concentrate urine properly due to the lack of antidiuretic hormone. And the primary issue that you need to remember here in diabetes insipidus is not kidney failure, but the deficiency in the antidiuretic hormone, which is not addressed here. Letter B is also incorrect because thyroid dysfunction can affect metabolism and energy level, but it does not, or is not related to the excessive urination that you see in diabetes insipidus. Again, diabetes insipidus specifically is a disorder of water regulation, and it is not associated with thyroid function. Okay, the thyroid does not play a role in the regulation of water balance or urine production. Letter C, another incorrect option here. It's because pancreatic islet cells are involved in what? Regulating the blood sugar through the insulin and glucagon, but not in regulating water balance. So the option in letter C is talking about diabetes mellitus, which is a totally different disorder. And this is all about pancreatic dysfunction, not talking about the diabetes insipidus. So eliminate this one right away. And so for you to correctly answer this question, I want you to focus on the core issue with the diabetes insipidus. Again, this is the lack of the antidiuretic hormone, or the kidney's inability to respond to the antidiuretic hormone, right? So you need to look for answer choices that can address hormone imbalance or gland dysfunction. Let's have number 70. A client with congestive heart failure has been ordered to take levothyroxine synthroid by mouth. What is the nurse's next step? A. Administer the medication as prescribed. B. Inquire why the client is taking synthroid. C. Contact the pharmacist for clarification about the order. D. Obtain an order for serum thyroid function levels. You need to select letter D this time. It's because clients with CHF require careful monitoring when prescribed levothyroxine, and because excessive thyroid hormone, possible excessive thyroid hormone, when there is inadvertent excess of the external source of the thyroid hormone, this can increase myocardial oxygen demand. It can also exacerbate the heart failure, and it can also trigger arrhythmias or their angina. And so before you administer the medication, the nurse should confirm whether the client requires thyroid hormone replacement by at least obtaining an order for thyroid function tests. These are your TSH, free T4. You need to have baseline information about the thyroid function levels, so to ensure that the medication is appropriate and safe for this patient. Why is letter A incorrect here? We know that following the provider's order is important, but we know that levothyroxine can also precipitate cardiac complications, especially in CHF clients. And so the nurse should first verify the need for the therapy through thyroid function test. Letter B is also incorrect. We know that understanding the indication is good practice, but it does not ensure medication safety. Again, thyroid function tests will provide you the objective data to guide the administration. What about letter C? Contact the pharmacist for clarification about the order. This is also incorrect. We know that the pharmacist can provide you drug-related information. Only the prescriber can order thyroid function tests, so to determine whether the client really needs the medication. So for you to strategize in answering this question, you need to be familiarized that medications such as this one can exacerbate any pre-existing conditions such as this one, and assessment such as reviewing baseline data of the thyroid function level is very critical. Okay, you need to verify first the thyroid function, because this will ensure safe medication administration, and again, it aligns with the assess before implementing principle in the nursing practice. Let's have number 71. A client previously diagnosed with alcohol dependency now has Wernicke encephalopathy associated with Korsakoff syndrome. What treatment should the nurse expect to be prescribed? A. Oral chlorpromazine. B. Standard phenothiazine. C. Controlled use of antipsychotic medications. D. Thiamine injections. So this question focuses on the Wernicke encephalopathy and the Korsakoff syndrome conditions often associated with chronic alcohol dependency. And the critical aspect of this question is to understand the treatment options and identify the most appropriate interventions based on the pathophysiology of these disorders. And so what you need to do here before you answer is to look for the key terms, words Wernicke and encephalopathy, Korsakoff syndrome. These are important because these conditions are associated with thiamine deficiency, vitamin B1 deficiency, and this should immediately direct your focus to treatments related to thiamine supplementations. You also need to eliminate medications that contradict the patient's condition. And the question again is about alcohol dependency and its complications. So the treatments that may exacerbate liver issues or can cause toxic side effects in a debilitated patient, like antipsychotics, should be ruled out. And so the answer is letter D, thiamine injections. Okay, This is the primary cause. The thiamine deficiency is the primary cause, and so we are going to treat the patient with this medication. And I want you to recall that thiamine is very important in the neurological function, and whenever there is deficiency, it can lead to the nerve damage. There is going to be impaired glucose metabolism, and there's also degeneration of myelin sheaths. And so for this reason, thiamine injections are the primary management for this condition. Okay, so the injection form is often used initially to quickly replenish thiamine stores, especially in alcohol-dependent patients who may have difficulty absorbing nutrients. Why is letter A incorrect? It's because the chlorpromazine is a neuroleptic antipsychotic, and I want you to remember that neuroleptics are contraindicated in patients with alcohol-related brain disorders like Wernicke encephalopathy and Korsakoff syndrome. It is also hepatotoxic. It means that it could further damage the liver, which is an issue for alcohol-dependent clients who often have liver issues. Letter B, standard phenothiazine, is incorrect because, like chlorpromazine, phenothiazines are also neuroleptics that could worsen the client's condition. And these medications are hepatotoxic and could also lead to the liver damage, which is especially dangerous for alcohol-dependent clients. And they also do not address the underlying thiamine deficiency, which is causing the neurological symptoms. Letter C is also incorrect because the use of the antipsychotic medications in this scenario is inappropriate. These medications can carry a higher risk of toxic side effects, particularly in older or debilitated individuals, such as those with a chronic alcohol dependency. And moreover, the antipsychotics do not treat thiamine deficiency, and that is the central issue in this question. So for you to correctly target in answering this question, I want you to first identify the underlying cause of the condition. Again, there is vitamin B1 deficiency. Okay, I want you to recall the concept of the Wernicke encephalopathy and the Korsakoff syndrome. It's all about vitamin B1 deficiency. 72. During active labor, a client's cervix has dilated to 7 centimeters and the presenting part is low in the mid-pelvis. To help ease her discomfort during contractions, what technique should the nurse advise the partner to use? A. Engage in pelvic rocking with her. B. Practice the panting method during contractions. C. Initiate a rhythm of patterned breathing. D. Encourage her to take slow, deep breaths. So this question is assessing your understanding of labor stages and pain management techniques. And the key clues in the questions are active labor. This means the cervix is dilated between 6 to 10 centimeters and the contractions are more intense. There's also the clue, cervix has been dilated to 7 centimeters. This is indicating that the client is in the active phase of the first stage of labor, not yet in the transition phase. Also, the presenting part is low in the mid-pelvis. So the baby is descending but not crowning yet. So the techniques related to delaying birth wouldn't be appropriate. Also, ease her discomfort. So another clue for you. So the goal here is to help with pain relief during this stage. Now, what is the correct answer to answer this question? Or what is the correct answer, rather? So that is letter D. This is the best option because slow, deep breathing can help with pain control. It also promotes oxygenation. It prevents excessive tension in the abdominal muscles. And it also allows the uterus to expand comfortably without increasing intra-abdominal pressure, which can worsen the discomfort. And this technique is also useful throughout labor and is not specific to just one stage. so making it as the safest and most effective choice at 7 centimeters dilation. Okay, now why is letter A incorrect? Because pelvic rocking is helpful for back labor, which is caused by fetal malposition, let's say occiput posterior position. And the question does not indicate that the client is experiencing back labor. So this choice is not the most appropriate pain relief strategy. Letter B is also incorrect. Panting, which is short, shallow breaths, is used to prevent pushing when the baby's head is crowning before full dilation. And since the client is only at 7 centimeters, pushing is not an issue yet. So making this option inappropriate. Letter C, another incorrect option. It's because patterned breathing, or the hee-hee-ho, is often taught for transition phase. It's when the mother will have 8 to 10 centimeters dilation and when the contractions are at their peak intensity. Now, the case scenario here says that the client is at 7 centimeters, so she is not yet in the transition phase, and the breathing pattern may be premature or unnecessary at this time. All right, so when you answer this question, I want you to recognize first the labor stage, and the question states the client is still at 7 centimeter dilation, meaning the client is in the active phase of labor. So you choose an intervention that fits in this stage. And very importantly, you need to eliminate those options that are specific to other stages, such as pelvic rocking. This is used for back labor, not general contraction pain. And the panting is used when crowning to prevent early pushing. And the pattern breathing in option C is used in transition phase when there is 8 to 10 centimeter dilation and not in active labor. So you have to choose a universal pain relief technique, slow, deep breathing, which is effective throughout labor. 73. An 11-month-old infant has a cleft palate, and the parent asks the nurse why it's important to have the palate repaired before the child turns 2 years old. How should the nurse explain this recommendation? A. Surgery after age 2 may be more traumatic and should be avoided if possible. B. The eruption of the 2-year molars can complicate the surgery. C. The surgery should be done before your child develops improper speech habits. D. As your child grows older, the palate becomes whiter and harder to repair. This question is actually testing your understanding of the developmental milestones and the impact of cleft palate on speech development. And so you need to pay attention to the following clues in the question. This includes before the child turns 2 years old. Huge clue right there. So this suggests an important developmental reason for early surgery. And also this one right here, why it's important to have the palate repaired before the child turns. So this focus is on the functional and developmental impact of delaying surgery, not just the structural issue. And the answer should address a consequence of delaying the repair. So you need to look for that option that directly explains the reason for early intervention. And so the correct option here is letter C. Okay, the surgery should be done before your child develops improper speech habits. Take note that speech development typically begins between 12 to 18 months, and children start forming words and sentences by age 2. And the cleft palate affects speech because the child cannot properly control airflow and produce certain sounds, leading to nasal sounding or unintelligible speech. And I want you to recall that early repair before 18 months improves the chances of normal speech development, and it can also reduce the need for extensive speech therapy later on. That is why our correct answer here, it is letter C. Why is letter A incorrect? We know that surgery at a younger age might be easier emotionally, but this is not the main reason for the early repair. Okay? There are many surgeries even after age 2 and can still be done successfully without excessive trauma. So you need to eliminate this option because it focuses on the emotional impact rather than developmental necessity. Okay? Again, take note about the clues that I've already shown you earlier in the question stem. Letter B is also incorrect because the presence of 2-year molars is not a significant factor in determining the client palate or the cleft palate repair timing. And children with cleft palates may require those orthodontic treatment for years, but molars alone do not interfere with the initial surgical repair. And so this choice misleads the test taker into focusing on the dental factors instead of the functional issue, which is speech development. Now, letter D is another incorrect option. Why is that? I want you to recall that palatal growth does make later surgeries more complex. That's true. But this is not the main reason for early intervention. And many of cleft palate repairs can require multiple surgeries as the child grows, and so timing is based more on speech development than structural difficulty. And this answer might seem reasonable, but it does not address the primary concern, which is speech and language development. So for you to answer this question correctly, you have to focus on the function, not just the structure. And the question asks why the repair is done before age 2. So think about what happens developmentally at this stage, and that is speech formation. Okay? And I want you to eliminate those answers that focus on emotional or structural concerns. The key issue is speech development, not trauma, teeth, or surgical complexity. 74. The parents of an infant who recently underwent ventriculoperitoneal shunt placement for hydrocephalus are worried about the child's outlook. What should the nurse explain to them? A. Any brain damage present at birth is permanent and won't improve even after the first year. B. The long-term outlook is very good and the shunt will remain in place permanently. C. As your child grows, the shunt may require adjustments or replacement. D. Hydrocephalus typically resolves on its own by age 2 and the shunt can be removed at that time. So this question is testing your knowledge about ventriculoperitoneal shunts and the long-term management of the hydrocephalus. Now, I want you to pay attention to the following clues in the question. It said here, infant who recently underwent ventriculoperitoneal shunt placement. So this tells you that the baby has hydrocephalus that requires lifelong management. Okay. Now, another set of clues here. We have parents. The word parents are worried about the child's outlook. So the best response should provide realistic but also supportive information about long-term care. And you need to look for that option that addresses both the future management of the shunt and the child's development. Now, the correct answer here is letter C. And why is that? It states, as your child grows, the shunt may require adjustments for or replacement. So I want you to recall that ventriculoperitoneal shunts do not last a lifetime without modifications. So they must be adjusted or replaced as the child grows older. And so the tubing length may also be increased periodically to accommodate their growth. And shunt malfunctions and infections can happen along the way, so it will require interventions and possible replacement. And so this answer is the most accurate, and it will also provide essential long-term expectations for the parents. Letter A. is incorrect here. And why is that? Because this overgeneralizes the prognosis. We know that severe brain damage may be permanent, but many infants can show neurological improvement in the first year due to brain plasticity. And so this answer is too pessimistic, and it doesn't really offer hope, or it doesn't really offer useful information. What about letter B here? Another incorrect option. We know that many children with shunts can live their full lives. Saying that outlook is very good is an oversimplification, because complications can actually happen. And the shunt may not remain in place permanently in its original form. It will need adjustments, it will need revisions or replacement over time. And so this is another misleading statement into causing the parents to think the shunt is a one-time procedure, which is incorrect. Letter D, another incorrect option here. This is completely false, because hydrocephalus does not resolve on its own in most cases, and the ventriculoperitoneal shunts are usually lifelong unless there is a rare case of resolving hydrocephalus, such as after a temporary cause like meningitis. And this option gives false reassurance, which can be harmful, right? So I want you to apply clinical or critical key strategies here. You need to look for answers that provide accurate, realistic information, and the best response should set appropriate expectations for long-term shunt management. And I need you to be aware of extreme answers such as permanent damage or hydrocephalus resolve on its own. These are usually too absolute and oversimplified. And I want you to pay attention also to words like permanently and typically resolves. These are red flags because they suggest incorrect assumptions about lifelong conditions. Let's have number 75. A client is admitted with a femoral neck fracture. How should the nurse position the affected leg? A, rotate it outward with the knee and hip slightly bent. B, turned inward with the knee and hip extended. C, rotated outward while keeping the knee and hip straight. D, turned inward with both the knee and hip flexed. This question is testing your knowledge of proper positioning for a femoral neck fracture to prevent further misalignment and complications. So your key clues into this question are the following. We have the femoral neck fracture. This means the break is in the upper portion of the femur near the hip joint. Also, proper leg positioning is important here, okay? Positioning to avoid further displacement and misalignment. So I want you to look for that answer that promotes alignment and prevents external rotation. And so the correct answer is letter B. I want you to remember that a fractured femoral neck causes the leg to naturally rotate outward and also shorten due to the muscle pull. And so the correct position is slightly internal rotation with extension to maintain alignment and to prevent further displacement. And this option can also help stabilize the fracture. It will keep the leg in the correct position before surgery or the placement of a traction. Letter A is incorrect because external rotation, this is external rotation, is the natural deformity in the femoral neck fracture. So it can leave it in this position leaving this in this position could also worsen the displacement. And the statement right here, hip slightly bent, is not ideal because it can increase the risk of contractures and misalignment. Letter C is also incorrect. This is rotated outward while keeping the knee and hip straight. Again, external rotation is the problem. It's not the solution. So you need to keep the knee and hip straight, okay? But the leg should be slightly internally rotated instead of externally rotated. Letter D, another incorrect option. This is stating turned inward with both the knee and hip flex. This portion right here is correct, but the flexion of the knee and the hip is incorrect because it can cause additional strain and misalignment. Okay, so the correct position for this client is internal rotation with extension, not flexion. So for you to answer this question correctly, I want you to know the natural deformity of a femoral neck fracture. So the leg naturally shortens and this will rotate outward. So the treatment involves counteracting this by maintaining internal rotation and extension, not flexion. So you got to be cautious to those test options that involve external rotation. Remove them right away. So if they're mentioned, it's likely incorrect because external rotation can worsen the misalignment. And also to avoid the flexion unless it is specifically indicated by the prescriber, because again, flexion can cause additional misalignment and it is not preferred positioning for a femoral neck fracture. So that's the end of our test questions for today. Again, we are inviting you to enroll to the NCLEX course via Stankos, NCLEXcoaching.com. And also I want you to remember that every question that you're answering in this series can build your critical thinking and your confidence. So I want you to keep pushing forward. You need to stay focused, trust your preparation, and also believe in yourself. You've got this. So I'll see you again in our next Q&A series.